As we kick this off, first of all, I want to just welcome everyone here and thank everyone for attending. We all care about this very deeply. I know everyone in this room is here for a different reason, but we really appreciate everybody participating. I'd like us to start with just a moment of silence. A moment of silence as we think about the impact mental health has had on our community, maybe on our family members, maybe even on our own mental health. It's a serious topic, and you'll see at your tables a green pen. I have one here on my badge. And the green ribbon is the pen for mental health awareness. So we'll start a little bit with the why. There's a national mental health crisis. That's not news to anyone in this room. It impacts our community as well in many deep ways. We'll hear more about that later today. We'll hear some national and regional statistics. We have a lot of great speakers here to provide information and hopefully some inspiration as well. At St. Elizabeth, we care about the health of our community. We also care about the health of our associates. We're doing some things internally to address mental health through Target Health and through our Vision campaign, which is focusing on physical and mental health of our associates. We recognize that in order to have a broader impact on community mental health, we need help from a lot of our community partners. We all need to work together on this. So that is our goal here, to bring a whole bunch of stakeholders together and just start the conversation about what can we do together to address some of these issues in our community. So St. Elizabeth's strategic plan, we do this on a 3-year process. We did it in 2022. This is our 2023 through 25 strategic plan. You can see one of our strategies is to be a community convener. We want to be the best community partner to everyone in our community and do what we can to fulfill our vision of making our communities the healthiest in the nation. As part of our community convener strategy, we've decided to invite you all here today to have this important conversation. So St. Elizabeth's role in community outreach is fairly broad. You can see that we do a lot of things in that space. Our community health needs assessment, which we also do every 3 years. It's consistently identified needs in the area of mental health and substance use disorder. Today, we're not going to be focusing specifically on substance use disorder. There are a lot of other specific initiatives that focus on that. But of course, there's a huge intersection between substance use disorder and mental health. So we will be talking about that a little bit peripherally. And our goal, again, is to strive to work collaboratively with our community partners to address problems that we can't solve alone. So a little bit about the planning process for this summit. It included conversations with many local stakeholders, and this is really one of this. It takes a village or even a couple of villages to get this together. We talked to a whole lot of folks, and I just want to broadly thank everyone who participated in the planning process. But I will call out a few folks. We had a lot of conversations with local community leaders, including our judge executives for both Boone, Kenton, and Campbell counties. I know Judge Knockelman is here, and I believe that Judge Moore was also going to join us. Our local representative, Kim Mosier, was involved in the planning process. Greg Duncan from Indiana and the Community Mental Health Center, and many leaders from mental health providers in our area, not just St. Elizabeth, but Sun, Health Point, North Key, Cincinnati Children's Home in Northern Kentucky, and Interact for Health as well. Other nonprofit organizations such as the Alzheimer's Association and the Joe Burrow Foundation and Brighton Center, who's helping us with catering today. So really a broad group of folks invested in this. We also talked to law enforcement, first responders, educational institutions, faith-based organizations, and some folks who work in the judicial system. There's a big interface, as you might imagine, between chronic mentally ill and our judicial process. And then finally, I really want to shout out our SEP and SEH planning teams. This was a collaborative effort between St. Elizabeth Physicians and St. Elizabeth Healthcare. There were too many people involved to thank them all, but I just want to call out on the St. Elizabeth Healthcare side, Sarah Giolando, Sarah Hamilton, and Roseanne Niels for their work here. And also on the St. Elizabeth Physicians side, Ann Beers, Jake Bast, Terry Offerman, and of course, Christina Bryant, who'll be speaking today. Just a little bit about our format and what to expect today. We're going to review our current mental health statistics, our current resources, maybe talk about some gaps. And this afternoon, we'll have an opportunity to work collaboratively, hopefully to create some action plans and just discuss a strategy for 2024. The way that the session is organized today, we'll be talking about child and adolescent mental health, then we'll be talking about chronically mentally ill adults and the geriatric mentally ill. And I'd like to kick us off with a quote. This is from Kristen Bell, an American actress. "Anyone can be affected by mental illness despite their level of success or their place on the food chain. In fact, there is a good chance that you know someone who is struggling with it, since nearly 20% of American adults face some form of mental illness in their lifetime. So why aren't we talking about it?" Well, today we're here to talk about it. So let's start the conversation. I'd like to bring up Christina Bryant first. She's our SEP Senior Consultant for Organizational Effectiveness.
Hi, good morning, everybody. So as Dr. Murley said, my name is Christina Bryant, and I have had the privilege to be a part of the planning that has put the summit here today. I've had conversations with so many of you in this room, and it's so great to see you here in person and collaborating towards this important effort. Many of you remember we sent out a questionnaire early on in our planning process that we really just kind of wanted to go over today and talk about how we utilized it for the content and the direction that we're going to be providing today. So when we think about the why, Dr. Murley touched on it a little bit, but as we started talking to many of you, we heard about the societal impact that mental health can have. We heard about overcrowded jails, our extended wait times in the ER, absenteeism in schools from our children, exacerbated health issues, and many that are going on disability. So we wanted to take that and really capture it, and that's when we put our survey together. So the survey was created specifically for the summit. We had it open just really for the month of May, closed it in early June. As Dr. Murley said, we offered it to a variety of our community stakeholders, really trying to capture anybody that had a touch on mental health. And then we used those responses to look at the content that we wanted to provide today. We wanted it to really reflect the current state that everybody was seeing and that people were talking about. So looking at the participants, you can see here we were so happy. We had a total of 205 responses. You can see the top response was coming from healthcare providers. Now, as we looked at that, we're not thinking that those are necessarily folks that are providing direct mental health services, but those also reflect RNs, social workers, and some other licensed folks that we have in the healthcare setting. And then you can see the variety of others that we had as well. Looking at the counties where services were provided for those that were a part of the survey, no surprise here as they reflect, some of the more highly populated areas, Kenton, Boone, and Campbell. So looking at the most common service needed, as we talked to many of you, this was not a surprise at all. Counseling was by far the runaway with this, and I think in talking to you, that just continued to be a point that was driven home. Looking at barriers, really aligns with the previous slide, right? We're not able to provide those counseling services if we don't have the providers that we need to do that. Also, that would affect the time that you're able to get into a counseling service, right? So nothing unusual here in terms of what we're hearing from you guys with the barriers. Priorities. This is where we had a free text box. We really wanted to hear from you as to what you thought was really the first or second priority on your mind. Access was something that stood out from many of you in these responses. In the blue, you can see those were kind of secondary to that. So community mental health education, eradicating stigma, crisis and trauma services, and communication between services. The yellow behind that just really kind of also supplements what we saw in the green and the blue. Ideas was also another free text box. So we really asked that you think of, an innovative idea that you had or maybe that your organization had on what you wanted to do to address those priorities that you identified. Centralized services and resources, that was something that we saw really in every answer. It was about how do we better communicate? How do we better collaborate? So you can see in blue there, centralized call center, parent and guardian education, wellness hubs, mental health awareness community events, and mobile treatment units. So at St. Elizabeth, we shared a little bit about our community convener, but I also wanted to talk a little bit about our vision. So our vision says that we want to lead the communities we serve to be among the healthiest in the nation. And certainly that encompasses mental health. We want to take today to collaborate with you and work together as we recognize that that is not going to be done by us alone, that we need everybody in this room working together for the good of those that we're serving in our community. Thank you.
Next, I'd like to invite up Teresa Brain. Teresa leads GIST Healthcare's development of strategic and operational insights for members and advises health system leaders on a variety of strategic initiatives. Prior to joining GIST, Teresa spent over 13 years at the advisory board, now part of UnitedHealth's Optum division, and there she served as a managing director. So she's going to talk to us a little bit about the national landscape, healthcare state of the union amid the mental health crisis.
Okay, great. Seems to be working. I didn't wear something with pockets today, so hopefully this doesn't fall off. So good morning, everyone. Thank you so much for allowing me to be part of your day. As Dr. Murley said, I am with GIST Healthcare, which is a small healthcare consulting group founded by two former advisory board colleagues of mine, Chaz Rhodes and Lisa Belamovich. They broke away when the advisory board, which is an organization that many of you might have seen over the years, was acquired by UnitedHealthcare's Optum division. And I joined them in 2019. So we are a small but mighty team working with St. Elizabeth Physicians, and many other health systems and provider organizations across the country, really on a lot of strategic planning and strategic positioning of healthcare in this change time. So doing a lot of 2025, now it's 2030 visioning. And happy to bring a little bit of that in the context of behavioral health, mental health issues to this group. Really just to give that kind of 30,000 foot view, connecting the dots to a lot of the issues that I think will come up naturally across the day, and some of which Robin has already brought up. So have a handful of slides here, and then if there's any time at the end, happy to take questions or at the break. One thing about GIST Healthcare, if you're interested in healthcare issues or want to get more up to speed on provider issues, we have a daily podcast called GIST Healthcare Daily. We also have a weekly newsletter called The Weekly Gist, both of which free and available to everybody. Our website is gisthealthcare.com. So if you are excited to see any of this data or want some more analysis on it, wanted to invite you all to take a part of that. And with that being said, I also, feel a little bit teary. I have a 7-year-old in second grade, just went to back to school night, and I feel like the older I get, and now that I have children, the more that these issues hit home. So thank you so much to everybody who's a teacher. I've learned that, obviously it's going to be a long road ahead having a child in elementary school. But moving on here, let's see if I can advance this. Whoops. Green, there we go. I did learn that. All right, market forces. So a lot is going on in healthcare. A lot is going on in mental health care, but the healthcare business model at large, from all parts of it, is experiencing a lot of different market forces, a lot of different pressures. And so I collected a handful of these slides just to illustrate the 4 major drivers that you see here. So the economy. Everything from inflation, interest rates, recession risk. A lot of folks in our healthcare ecosystem are feeling pressured when it comes to operating margin, when it comes to investment margin. And that's putting a lot of pressure on different parts of the health system. We have a lot of rural hospitals that are closing in areas like the ones that we've just been talking about. So, maybe that 40-minute drive to the ER is now an hour-and-a-half drive. And there's going to be a lot of continued focus there as well. due to the other forces here. So the labor market, that's something that's impacting hospitals, health systems, physician groups, probably all of your associations and activities as well. Everything from teachers to everybody across the board, counselors, therapists, huge labor shortages, huge unionization activities, strikes, things like that, creating a lot of fluctuation and a lot of questions as to organizations, how they're hiring, how they're retaining, and demand changes happening across the board. As Robin said, and as I will show, huge uptick in demand needed for different things along the behavioral health spectrum. Also huge demand changes as the baby boomers age, as care shifts outpatient. There's a lot of change ahead for healthcare systems in general. And then new competitors, so different types of folks on the scene, some of which might be reflected in the audience of this room. Used to be healthcare was health systems, physician groups, others like that. Now there's a lot of healthcare and a lot of mental health care being delivered online through virtual visit companies, as well as at your local CVS and increasingly through Amazon and others. Ultimately, this could be harnessed for good. This could allow increased capacity and increased availability and access for patients. But it will no doubt create fragmentation, which is something that is really hard for a lot of folks that are already seeking mental health care treatment. All these forces together are going to make everybody who touches this spectrum, whether a healthcare provider, whether an affiliated agency organization, have to think differently about their organization's future. So just a couple of highlights here. As I mentioned, things are hard. This is probably true for many. This is health systems in general. You probably have seen, like I said, hospitals closing in different regions. A lot of different layoffs are happening across the board. This is because health systems in particular are experiencing operating margins that are very pressured. And that's, like I said, due to a lot of the labor cost increases as well as the various ways that their business is being affected post-pandemic. And what this actually shows is that even compared to past times of financial challenge, like the dot-com bubble burst back in the early 2000s, as well as the 2008 recession, more hospitals right now have operating margins that are in the negative. And it's actually I think it's 53%, can't read that stat from here. So over half. And that's going to lead to not only closures, like I said, but also different types of consolidation. So it might be that the hospital in town still survives, but they join a larger health system. Now they don't have maternity services. Or maybe they close their inpatient their inpatient behavioral health unit, which is another one that's often happening when folks merge. And so this type of backdrop definitely makes your affiliations with others in the healthcare space more challenging. But importantly, that high-level view is also being felt by probably many of us in the room right now who are experiencing the great increase in healthcare prices, and the fact that the majority of Americans are now on high-deductible health plans, and not just a deductible that used to be considered high 10 years ago, which was $600, $700, but a deductible that's upwards of $1,500. And so even if we think about providing healthcare services and access, a lot of that is out of pocket and this is for an individual. For a family, that might be $3,000. Effectively, we are now cash paying, so to speak, for our healthcare, which could also be a barrier to folks seeking treatment that your organizations provide. And many of them are therefore deferring care. And some of that care is actually things that are covered under the Affordable Care Act. Preventive services are covered, mammograms, things like that. But when folks face a high deductible or get hit by, their first healthcare bill, they might think, okay, I can't access that again. And so that is definitely on the rise. Medical debt, huge issue that impacts Americans. There actually might be movement on that front. Some of you might have seen that this week President Biden announced that he'd like to be able to eliminate medical debt from Americans' credit reports. Because right now, statistic is pretty crazy. It's like 40%, I think, of Americans have medical debt right now. And that's impacting their ability to get jobs, their ability to rent an apartment. So huge issue when we think about how the greater economic trends that this country are facing are trickling down to folks' individual decisions. And those things on the right, it's a matter of, paying $3 or $4 or whatever eggs might be in your market to, making that decision about a counseling appointment that might be $80 out of pocket. There's also the labor point, as I made. This graphic is a little confusing, but just to unpack it, hospital employment is the blue line, nursing facility employment is the yellow line, physician office employment is the teal, and then private sector employment is the gray. And so what this is looking at is post-pandemic, actually goes back to in 2019. It's hospitals and nursing facilities that have seen the greatest pay increases to offset the huge drops in employment that they saw with the pandemic. So there's been a lot of folks leaving healthcare, a lot of nurses that left during the pandemic, some left right after. Lots of baby boomer nurses are retiring, and healthcare institutions, whether hospitals, nursing facilities, physicians, they've had to raise pay, and a lot of union activity has focused on payment increases in order to lure folks back to the setting. Nursing facilities, which obviously impact a lot of seniors, those folks are still struggling, and they're facing new regulations for staffing right now too. So this continues to be probably the biggest driver of that hospital margin pressure that I was just speaking of. And this impacts probably most organizations across the board, whether you're in healthcare, in any community organizations, frankly, any company right now, which is a huge turnover happening as well. So even if we're able to increase wages and hire folks in to, say, therapists, counseling roles, all the roles we desperately need to fill, there's increasingly high turnover and high vacancy rates as well. There's a lot of dissatisfaction and burnout, happening across the board, whether physicians, nurses, teachers, and we're seeing a lot of continued unrest. And so a huge challenge as we think about all of the work and all of the ways we'd like to expand healthcare in all facets when it comes to how we're going to be thinking about this moving forward. And this has a lot of other ramifications too around staffing levels and licensure levels. And it's going to be just a big thing our nation has to tackle. How are we going to be able to hire and recruit enough people into the aging of America, into the growing youth mental health crisis, and into all of the changes that we know are coming. Amidst all this, like I mentioned, demand is hugely changing and shifting out of the hospital, out of the physician office to virtual, that's the top line there, to the outpatient space, the yellow line, to home, the blue one. This is huge for how healthcare is paid for, how we are set up to deliver it. More and more people are not going to be able to drive that 40 minutes or that hour and a half or however long it is, to go into any type of facility, especially if it's for a regular counseling appointment. We need to be thinking about how we are getting those services. I love, the stories of embedding primary care clinics and counselors in schools, and of course that's funding dependent, but that's the type of access that we need for this, especially given the availability that those services require. This also shows a little bit about outpatient surgeries and that type of shift, which might be a little bit outside the scope for today, but really important when we think about how many in healthcare have made money over the past couple of decades. It's by bringing in high revenue surgeries into the walls of the hospital. That's now shifting outpatient too, which is one of those main drivers for a lot of the concern that we're seeing in terms of closures and consolidation. And kind of coming one level down here from healthcare to behavioral health and mental health care, COVID, which I don't think I've said that word yet, or maybe I said it a couple minutes ago, but that has been a huge, huge change, right, as we all know, to not causing the mental health crisis, but certainly exacerbating it and maybe helping to bring it into the spotlight even more by the types of stats that are shown here. So the share of adults reporting anxiety and depression, 7.7% was already pretty high in 2019. That skyrocketed to 31% during the early days of the pandemic and has held pretty steady. So who knows, right? This might have been existing in our society and probably was underreported. But now I think we are at least wrapping our arms around how great the scale is here for how many folks need it. These are adults reporting it, not necessarily diagnosed with it. We have a huge, underdiagnosis problem. You can see it's estimated that about a third of adults have an unmet mental health care need. So huge demand that we might not even know about or be addressing to think about. And of course, the double click on substance abuse and drug overdoses, these deaths have sadly skyrocketed, driven by synthetic opioids. And that type of demand is really, as you can see the stat there, propelling a lot of overcrowding and just inability to access a lot of substance abuse facilities, especially on the inpatient side. So with this type of backdrop, we have also uncovered a whole new way of addressing some of this need. This is still pretty early days. But the key trend here on the outpatient behavioral health side, again at a national statistic level, is that virtual health has really changed the game here. Behavioral health accounts for the vast majority of virtual health being done. So right when the pandemic happened, you might recall and have seen physician offices closed and many healthcare outpatient facilities closed. And those virtual appointments were the only way that you could talk to your doctor. Many thought that that was going to revolutionize medical care across the board. We've seen a lot of drop off of that. A lot of physicians, the gastroenterologists and the cardiologists said, okay, back to work, I'd like to see patients in person. But where that stuck is when it comes to telehealth. And so that's what you see there, the bars looking at the left-hand side of the slide. The overall utilization of behavioral health care is up, but that's driven by those giant tall bars, driven by the telehealth utilization. And then over on the right, this shows that about 5.5% of total medical claims were virtual, of those 3.7. So can't do the math on the fly as well as I probably should, but about 2/3. And when it comes to looking at groups like ZocDoc, they schedule appointments. They're like a scheduling platform. 85% of psychiatry appointments that they help schedule with providers were virtual. Many companies have come to play, gotten tons of investment, some of which are shown at the bottom. Huge telehealth providers, Lyra, Talkspace, Teladoc, MDLive, and Amwell, they do virtual health across the board, but a great percentage of their business is virtual health. So these are providers that many of you in the room who are traditional providers and medical groups, you might not know that your patients are accessing healthcare through some of these providers, whether it's mental health care, whether it's urgent care. And this does fragment the way that you as a provider might think across the management of your patient. But for many, this is easy access, cash pay prices, tell you for $80 you can have an appointment, you don't need insurance. So these are players that are starting to disrupt the way that we think about the healthcare spectrum. And maybe a topic of conversation later this afternoon in some of your groups, if some of these folks have a heavy presence. Lots of employers offer these types of companies as benefits to their employees, including a lot of health systems. I mean, mental health needs are very high amongst actual providers of care, nurses and physicians, and Lyra in particular partners with many health systems to offer that type of care. And it's not just these tech companies or these virtual care companies, it's all of these giant retailers, right? Your corner store, the place you shop every day, a Walmart or an Amazon. They're not only just getting into virtual care and that type of thing, they're becoming full-service primary care providers. And that's very important because, if 30% of adults have anxiety, depression, the US Preventive Service Task Force earlier this year also recommended anxiety screening for all adults. I think it's 18 to 64. As people adopt that standard, we're gonna probably raise that statistic of diagnosed depression and anxiety. And that's not gonna be all able to be seen by a mental health professional, or I should say a psychiatrist, psychologist, counselor. Primary care physicians are gonna have to be taking on a lot of that as well. These folks, the CVSs, the Walgreens, the Walmarts, the Amazons, they're also aiming to expand full service primary care to communities through various means of physical and virtual. And a lot of that is going to be changing the way that we think about what it means to access care. These companies also there on the right are also getting into Medicare Advantage in a big way as well. And a lot of them are very much aligned with payers, but huge difference for how we think about it. And a lot of the value proposition of a Walmart, Dollar General is also getting into healthcare delivery is because of that lack of access, as Robin talked about in rural areas. And that's huge also when it comes to mental health access. So you can see here that rural Americans report much more, no surprise, difficulty accessing mental health services, lack of providers in rural areas, lack of insurance, and a less of a ability to accept mental health services as well. So when we think about that, that's where some of those virtual players, some of those retail providers might come into play by allowing folks, a lot of people like the privacy of an online appointment. So definitely targets on the rural area. And as Robin highlighted, in particular, this is a youth mental health crisis as well. I think that's probably something that's newer, that is really pandemic accelerated. Of course, you might argue Instagram and all those types of things have been driving a lot of this before the pandemic, but I think the pandemic certainly exacerbated it, with Gen Z saying that they felt like their mental health worsened. Almost 1 in 2 Gen Zers saying that their mental health has worsened. And that's reflected on this youth mental health related ED encounters. So any mental health diagnosis is the blue line. You can see it's just about doubled in the past 10 years. And suicide related almost quadrupling in the last 10 years when it comes to youth mental health crisis. There on the right is a interesting study. It's sourced in the bottom if you want to read more. It takes from the Boston, Massachusetts area, I believe, that looked specifically at youth psychiatric ED boarding. Huge issue, as Robin said. And basically, after the pandemic, more youth were boarded coming out of these were youth that were evaluated first by a mobile crisis team. And then fewer were able to be discharged to an inpatient unit after boarding because there just wasn't the capacity. And these are all the stories that I'm sure we've read. They've been, in the press about, some youth spending months living in the ED. But across the board, moving to the whole population from youth, we still have high mental health volumes. You could look at that data and say, well, it's gotten a little bit better as the pandemic has gone on. But importantly, most areas are at capacity when it comes to inpatient utilization. And so what do you do with that patient that's boarded in the ED? Where do you send them? And that has downstream impacts on, not only the patient, they're having a delay for care, more likely to have medication errors. I mean, the ED is the worst place to have a mental health episode. That impacts providers in many ways, from burnout and, but also to, threat of physical violence, that type of thing, and that it impacts the entire care system down the road. I think this is one of my last slides here. All of this adds up, as Robin had a slide on as well, to this greater socioeconomic impact that we as a nation are facing. And our healthcare quick overview of the provider landscape, like I replied, this has a huge goal to work together and to figure out how we are addressing the fact that as a society, we are having huge, when you put a number on it, billions and billions of billions of dollars, loss of earnings, healthcare expenditures, disability benefits. That's what all of the, crisis in our schools, from lower attendance and workforce absenteeism, homelessness, all of those things add up. And importantly, there in the call out, depression and anxiety have been linked to higher risk of other ailments as well. So when we think about helping our patients from a mental health perspective, there's also a lot of connectedness as it comes to just helping them from a health perspective. And so just a slide that might be, one to start getting your thinking for your afternoon breakout sessions. Lots of potential solutions. I mean, you all represent organizations in the community that probably fall along this spectrum somewhere when it relates to goals like ED diversion, inpatient admission diversion, all kinds of things that the community can do that go way, way upstream, right? Starting in first grade, starting in kindergarten, from educating community and having kids develop tools, things like that. But then, all kinds of telepsychiatry and, different ways that we're seeing folks collaborate on these challenges. And just a couple of questions then as I close out that I would, challenge you all to think about. Like has been said before, every one of you in this room represents an organization that's doing something, and you probably have a partner across the room that can help you with the thing that you're not doing. And so there's a lot of available resources. And I think today's goal is really to take inventory of those and to think about, where are there opportunities to better collaborate? How can you all determine amongst the myriad of needs in this space, how you can prioritize addressing those together, and how you can really collaborate towards improving. Thank you so much. Those are my slides.
Thank you, Teresa. GIST has been a great partner in helping us really understand the national landscape for healthcare, and it's rapidly changing, as we all know. Now we'd like to get a little bit more local, closer to home. I'd like to bring up Ross Meyer. He is the VP of Strategy for Interact for Health, where he leads the foundation's work to improve mental health and well-being across the greater Cincinnati region. Previously, he served in executive roles at United Way of Greater Cincinnati and as Executive Director of Partners for a Competitive Workforce. So he's going to talk to us about the state of mental health in Northern Kentucky. Welcome.
Morning, everybody. It's such an honor to be with so many people who care deeply about the mental health and well-being of our community. Many thanks to the St. E's team for convening us together. This is the kind of challenge that takes all of us. So I'm going to talk a lot about the challenges, some more data. I'm sorry, I got more data for you, but it's about our community, it's about our neighbors, it's about us. And also hopefully some opportunities that can spark our conversation for later today about what we can do together. So first, I'm going to share a little bit about Interact for Health if you don't know us, and then I'm going to share data. I'm not a data guru, so I have a tremendous team at Interact that is on top of all the data. Many of you probably have better data than us, so hopefully this just sparks a conversation about where are some of the biggest challenges and opportunities that we see in the Northern Kentucky community. So a little bit about Interact. We are a regional grant maker and change maker, serving our tri-state region, focused on ensuring everybody in our community has the opportunity to live a full and healthy life. So we work with partners, many in this room, to really focus on advancing what we call health justice. I'm going to talk about that in a minute. It's how we think about tackling the root causes of many health inequities, including in mental health. This is our region. We serve the tri-state region, 20 counties, including 7 in Northern Kentucky. And I'm going to share data about Kentucky as a whole and data for Northern Kentucky as well. At Interact, again, we are focused squarely on tackling health disparity at its root. And in our analysis, any data that you look at around health disparity, these are the populations that in our region as a whole bear the brunt of health inequity. So much of our work focused specifically on closing gaps and creating more opportunity for our Black and brown communities, children in low-income families, rural communities, as we've talked about a lot today. I'm going to share some data about some of the tremendous opportunities and challenges that our rural communities face, and LGBTQ plus communities. I'm going to share some really troubling data with you about the particular challenges that especially our young people who identify with the LGBT community are facing regarding their mental health. Our strategy at Interact, I'm just going to touch on this in a minute. We're going to talk a lot about mental health, but it's important for you because it's how we frame our thinking and how we approach mental health. And I'm going to talk about this vision of health justice in a minute. But in addition to mental health being a primary focus, we went through strategic planning last year and heard from all of our community, hopefully many of you, that if we don't do anything else but focus on mental health, it'll be time and resources well spent. It was the number one issue, especially for youth, that we heard time and again in focus groups and data and community conversations that we are facing a crisis, as we all know, and we all need to lean in on it. So it is the singular health issue that we are taking on as a foundation. We're also focusing on deeper systemic issues around policies that get in the way of creating health opportunity for all of us around the social determinants of health and in mental health. A lot in mental health is broken because of policy. So we're focused on policy change and what we call community power building. I'm going to share with you in a minute. There are dramatic disparities, as we know, between communities in our region. And we are focused on partnering with the communities that face the greatest disparities and lack of access to opportunity, and really putting them in charge of defining the opportunities and the goals that they want to achieve in their community to create a healthier community and help them get there. It's not like we're coming with the solutions, we're partnering with them to really build their agency and voice to lead the kind of change that they want to see in their communities. And it all centers around this vision of health justice. So many of you might have seen this graphic before, perhaps just the middle two columns. That is helpful for us to think about the difference between taking an equality approach versus an equity approach. So if you recall Robin's stories about her two students and the very different situations that they're coming from, if the teacher took an equality approach, treated them exactly the same, obviously that would not serve the needs of the young man who faced significant ACEs, significant challenges, right? So again, an equality approach, same approach for everybody, does not consider the unique circumstances and challenges that folks are bringing into the classroom in this case, which is why we need to take a more equitable approach, which really focuses on providing more supports and more resources to those that are facing the greatest gaps, right? Which is absolutely what we need. The image on the left is a better representation of the reality, right, of what many in our community are facing, which are just vastly unequal opportunities. Which again, we need to absolutely take an equity approach to really right those situations and really address the gaps so that everyone has a fair shot. But what we're trying to advance is this concept of justice, which is really what would it look like to remove the barrier in the first place, to tackle it at the root. So when we think about mental health, we think absolutely about how do we increase access to care? How do we help people, and young people in particular, cope with the situations that they're in, but also how do we change that situation? How do we prevent ACEs in the first place so that we don't have to continue taking a more equitable approach? So I challenge us to think about what does a health justice approach look like in mental health? How do we not just address the crises that many of our young people and families and adults are facing today, but how do we also think about the root causes of those challenges and tackling it at the core? So that hopefully helps you understand how we think about these issues in mental health. Now I'm going to pivot hard and talk about a lot of data to give you a sense of how we think about understanding the health of our region and in particular the mental health challenges that many are facing. We start at the highest level, life expectancy. How long are we expected to live in this region? It's the best indicator of overall health, and we lag the nation as a region. Across our region and in Northern Kentucky, we live about 2 years less than the national average, which, as you can see, is also declining. But the gaps within our community are dramatic. The gaps within our community are dramatic, up to 20 years difference between neighborhoods within Northern Kentucky and within greater Cincinnati as a whole. So I just want you to think about this for a minute. 20 years of life based on where you were born into, the situation that you're born into, the community that you're born into, determining vastly different opportunities that you can live a full and healthy life. How much life is lived in 20 years? How many birthdays, how many celebrations, how many grandchildren, right? 20 years is a lot of life. And to have communities literally just miles apart, where folks are facing vastly different opportunities is the challenge that we at Interact think deeply about. How can we change the situation so everybody, again, can live a full and healthy life? And this absolutely has everything to do with the social drivers of health. As you all, I'm sure, well know, access to health care is a small piece of the picture. About 80% of health outcomes are driven by the conditions around us, right? Whether we have access to safe neighborhoods, affordable housing, good schools, good jobs, transportation, healthy food, right? All of these conditions around us determine our health and lead to these very dramatic disparities in health outcomes. This is a map for the region as a whole. You can see as an entire region, 26-year gap between some of our neighborhoods, the lowest life expectancies in parts of Newport and Covington, highest, no surprise, in Indian Hill. Obviously, money matters big time. Economic opportunity matters big time in determining opportunities in this community, in this country. This map, to explain it a little further, all the yellow areas are the lowest life expectancy, darker green, if you can make the differences out. The highest life expectancy, again, if you were gonna overlay a map of social vulnerability, it would look exactly the same. But importantly for us, in our region, you can see a lot of the yellow areas are in our urban core and in our rural communities. A lot of the same challenges for different reasons that our urban communities are facing as our rural communities are facing as well. So let's pivot a little bit to mental health. I share that context because we think about the context that gives rise to mental health and well-being around the social determinants of health as the same, right? These are social determinants of mental health as well. So we think about those issues as we think about mental health. This is important data that I want to share with you. This comes from our community. We conduct a community health status survey every couple of years at Interact for Health. It's a statistically relevant sample of our region. And this graph on the left is adults in our region reporting frequent mental distress. This is defined as more than half of the last month you experience significant mental distress, right? That's a pretty serious situation, right? As a region as a whole, about 17% of us experience frequent mental distress, but you can see some of the disparities here. Those who identify as LGBTQ+, 42%, the highest disparity of any that we break out the data by, the folks in our LGBTQ+ community experiencing significant mental distress. Those living in poverty, young adults, and we'll talk more about youth in a minute, and our rural communities. Again, we look at these disaggregated data points to understand where are the greatest challenges, who are the populations that are facing the greatest mental distress. You can see here the chart on the right for Northern Kentucky specifically at 18%, but a steady increase over the last 10 years of all of us and our neighbors reporting frequent mental distress. The chart on the left, I think, should be hopefully shocking to many of us. This is folks in our region reporting a depression diagnosis. 30%. You often hear the statistics around 1 in 5 experiencing mental health challenges. It should be more like 1 in 3. Because to have 30% of people in this region reporting that they've been diagnosed with depression is shocking, and you can see that's doubled since 1999 in Northern Kentucky specifically. Teresa shared a little bit about the access challenges in our rural communities. This is a quick stat on the right there about access to mental health services, the ratio of population to a mental health provider. In the nation, that ratio stands at 355 individuals per one provider. Northern Kentucky is about double that, 699 per one provider. But some of our rural counties, of course, are significant deserts in terms of mental health access. Grant County, the lowest in our region, 1,261 people per one provider in Grant County. We're talking about mental health today, but I want to share this because I think there's a lot of hope in this statistic. Many of us in this room have been focused on the opioid epidemic and tackling overdose. Many of you might have newer data than this. This goes through 2022. The top line is Northern Kentucky. We are still far too high above the state and the nation. But the important message here that I want you to take is the decrease. We are making progress because of a lot of people in this room and a lot of people across this community working together to really drive down overdose. And that is, I think, a sign of progress. While the state and the nation has increased, this community has driven it down. It's still far too high and still a lot of work to do, but a lot of collective action has resulted in actually moving a really hard needle as a region. So it's still far too high. We still have work to do. But for me, it gives me hope that when we work together in a concerted way, we can make progress on really hard issues. And much more work is still to come, but we can do it if we put our effort together. I want to talk a little bit about young people. This is some of the national stats. Teresa shared some of these. It's no surprise to anybody in this room that we're facing a youth mental health crisis. It's been declared time and time again. And really the pandemic just exacerbated some of the underlying challenges. I love this cartoon from the Enquirer. It really captures well a lot of what Robin shared about all the baggage that young people are bringing into schools today. And mental health now nationally, on a national level, 1 in 5 young people experiencing some sort of mental health disorder. It's really the leading cause of disability and poor life outcomes in young people today. And importantly, as opposed to many other health conditions, mental health shows up early. Half of all mental health disorders experienced throughout a lifetime show up by 14. Half of all. 3/4 by the age of 24. So we gotta intervene early is the bottom line there, right? These issues are showing up early, and the lag between symptoms and access to care is years. You can see the bottom statistic there. Suicide, tragically, is now the second leading cause of death among young people 10 to 34 years old. The vast majority of young people do not receive any mental health care. So we have a lot of work to do to change that trajectory. This is statistics for Kentucky as a whole that I think is pretty compelling. This breaks down, again, one of the greatest disparities that we see is the LGBTQ plus community. That's no surprise given the political environment that our LGBTQ community is facing right now. And it should not be a surprise to you, though it should be a call to action, where 70% of all LGBTQ plus students across Kentucky as a whole report feeling persistently sad or hopeless, compared to, which is also unacceptable, nearly 40% of all students. And you can see some of the other statistics around suicide. Again, much higher, double in many cases for our LGBTQ plus community, but across the board, too high, without any question. For Northern Kentucky specifically, this comes from the KIPP survey, 11,000 Northern Kentucky students surveyed in 2021, 21% reporting serious psychological distress, which is a composite measure of anxiety and depression that affects daily functioning. 1 in 5, again, of all of our students in Northern Kentucky. And you can see some of the other stats all the way down to 10% making a suicide plan. It is absolutely tragic and requires urgent collective action. I want to point to a resource. You can check this out on our website. In addition to all the data we look at, we hear from people, right? And stories in our region. We have a tremendous report that is compiled based on 100 conversations that we've done with people all across our region that really, I think, give life to a lot of the statistics that you're hearing about, both the challenges and the root causes of some of these challenges. I'll read a couple of these that relate to young people in Northern Kentucky. I live in a small town, conservative America, being so separated away from the queer community in general, it's very isolating. Here, I'm so guarded. Putting up a front is exhausting. It really wears you down because you don't feel like you can authentically be yourself out in public. Interestingly, we talk a lot about the stigma around mental health among the younger population is less. It's more normalized, but this is an interesting perspective that a lot of people my age somehow have some sort of trauma affecting us, depression, bipolar disorder. We've normalized it a lot instead of being able to actually encounter our feelings and actually heal from it. When people talk about certain things, we kind of take it as a joke, even death. So it's an interesting perspective that has become so destigmatized, so normalized that it minimizes the very serious conditions that young people are facing. So I just encourage you, as we're thinking about these efforts, to really put young people and the people experiencing them at the center, right? Because their stories can really illuminate some of the opportunities. Based on our engagement with a lot of partners, these are just some of the key barriers that we've seen, many that Teresa shared, that require our collective action, that are leading to some of these challenges in our region. We've talked a lot about the workforce shortages. They're just compounded in the mental health space, contributing to lack of access to care, and not enough providers that reflect the community that's being served. Parity continues to be a challenge. We think about, we fund, we treat mental health differently. We have for years in this country than physical health, and that leads to significant challenges and insignificant payment to really cover the cost of care, which again leads to provider burnout and folks leaving the workforce. We're talking a lot about folks in crisis, but there's a lot of effort that needs to be placed against prevention, right? Because we know that the challenges are just going to continue to grow. And this system is built entirely on responding to folks in crisis and only really intervening and providing resources when there's a diagnosis or even tragically a suicide attempt. And that's just wrong, right? We all know that. So how do we get more upstream and focus on early intervention and early support to really address it before it becomes a crisis? And stigma, while I think improved because COVID was a mental health crisis for all of us, we still hear specific challenges, especially in specific communities, in certain homes, that we haven't normalized mental health enough, and that continues to be a barrier to seeking help. All right, some of our opportunities that we see at Interact, we're focused very squarely on young people and strengthening the systems and supports for our young people. And we have started this work by really putting young people at the center and are supporting grantees, some in this room, with really listening to young people to really understand their experiences and what they want and need. A lot of adults talking about what we think young people need, but we really want to put young people at the center. So we have many of our partners in this room that are listening deeply to young people and retailoring services to be more responsive to what young people actually need. We're partnering with many across the region to strengthen school-based mental health. I appreciate Robin's example of the school-based health center. In her school, we've supported school-based health for years, and are really focusing on expanding mental health services, especially prevention services that we know work, but that are underfunded in schools around the region. And I'll share more about this, about a growing regional effort to come together around youth mental health that we're helping to convene. If that's not enough, we're also focused on a lot of the kind of systemic barriers from a policy standpoint. We're focused squarely on supporting advocacy efforts in Ohio and Kentucky to focus on the hard issues around parity, around workforce, around reimbursement that are standing in the way of the system working as it should. And we're focusing on doing what we can to help expand a more culturally relevant workforce. So that it's a lot, but we have a lot of opportunities that we see for making an impact. Now, I want to speak to this because it's an opportunity for next steps coming out of today. We'll work more this afternoon around opportunities to collaborate. But our community is coming together in a pretty exciting way around youth mental health specifically. We've helped convene a coalition of now 12 funders, including Joe Burrow Foundation, thank you, Robin, to come together, 12 foundations across our region to say we got to work as a community to develop a strategy to tackle youth mental health as a whole. Many of you were part of a convening last week. We had 100 organizations coming together to really deeply understand the challenges that youth are facing. We're listening to young people and engaging young people through focus groups to really put their voice at the center of this, to understand the opportunities and challenges, and then build a strategy that we as a whole across the entire region, across all these many systems from healthcare to community mental health, social service organizations, education, coming together to say, here's what we're going to do as a region to move the needle on these daunting challenges. We need more. We need all of you to engage with us. Just reach out to me. I'll be here all day, and we'll talk more this afternoon to get you plugged in, because there's many opportunities to engage in this work to help shape our region's strategy for tackling this issue. I want to close with just one more resource. If you didn't get enough data today, we have more. We have a resource that we are providing at Interact called Policy Map. It basically maps all the data that you look at from census, from anything, literally hundreds of thousands of data sources onto our region, so you can see what this data looks like for your community. And we're making this resource available to partners across our community. So if you're interested in getting a subscription, just reach out to me or Colleen, but you can reach out to me as well. But the data hopefully will help us understand what specifically is happening in what parts of our region that need addressing. So thank you, that's what I have to share. I just want to say, again, I think a lot can be done when we work collectively. We have tremendous resources and assets in this region, and a lot of hope and momentum that we can, in fact, make a difference on this seemingly insurmountable challenge, especially around youth mental health. But we have what it takes if we, as Robin said, focus on what we can control. And I appreciate all of your leadership and partnership in this endeavor. Thank you.
Ross, that was great. Thank you so much. Thank you to you and your presentation and all the work that Interact for Health is doing. We look forward to working with you this afternoon. So we're gonna start to move our focus to some of the groups that we kind of divided our day into. So you'll notice that we have the groups almost divided by age. We have child adolescent, we have chronically mentally ill adults, and then we have geriatrics. So we're gonna hear from some subject matter experts of those areas and the challenges specifically that they're seeing. So I wanna go ahead and introduce Dr. Beverly Smolansky. So she is coming us today from Cincinnati Children's. She is a child psychologist, associate chief of staff, and manager of patient outcomes and quality improvement there at Cincinnati Children's. That's a lot. You have a lot going on. She treats young children dealing with a range of fears, anxieties, coping problems, and obsessive compulsive disorder. She also helps preschoolers with behavior issues and evaluates them for attention deficit disorder, as we know, ADHD. So I'd like to go ahead and welcome Dr. Smolansky.
Thank you. You're welcome. Thank you. That is a lot. I have a long title underneath my name on my thing. I just want to start by thanking you so much for inviting us here. You know, we're on the other side of the river, but we are one of the bigger providers for children's mental health in the area. And so it was good to at least be invited. You're going to see a few slides that are a little bit of overlap of some of the statistics that you've already seen. I don't think that's a bad thing. I think of all of the statistics out there in the universe, we all are honing in on the exact same ones that we think are important. So really, this is sort of a state of the children and adolescent mental health care in the area. I don't know as much about in Kentucky, but I think it's kind of regional with the children. So I'm starting with this rather busy slide because when I was talking to the organizers, they liked this idea and wanted me to at least explain one thing that Children's is doing to really put their backing behind mental health in this area. When you think of, and this is not to talk down, so I apologize if this seems too juvenile, when you think of how do you manage all clinical care in a hospital, I explained it to my family as an octopus. And at the head of the octopus is the chief of staff and the people running all the clinical care. And each arm of the octopus is a service line, like the emergency department or the surgery or all of the outpatient clinics. Mental health was never included in that. Mental health was never part of that octopus. We did not have a seat at the adult table. We were sitting at the little kids table, and therefore it was really never part of the discussion. We have, is this the pointer? Here's the center, the head of the octopus, and each of these are arms of the services. We are now on there. So mental health, I know, this is a really big deal going into this mental health crisis because we now have, under the chief of staff office, mental health is at the table. We have 2 associate chiefs of staff now. I'm a psychologist and my partner is a psychiatrist. We have an operations person and then a nursing manager as the head of mental health within the hospital sitting at the adult table. And I have to tell you, I've been doing this just since May, and I have a lot to learn. They also don't exactly know what to do with me because I'm not an MD. I'm a psychologist, probably a little more touchy-feely and supportive than what they're really used to at the big kids table. But I'm working on that. And what I learned in the very beginning is, within the hospital setting at least, what mental health was is what was taking up the most oxygen in the room. And that's the emergency room and inpatient psychiatry. And yes, that's very important. And I promise to stop calling it the burning dumpster. But I'm trying to move attention away from just that. It's very important and we have work to do, but we also need to figure out what to do to keep the kids out of there. So they really wanted me to address this new role that I have as the Associate Chief of Staff for Mental Health within the hospital. So it really shows we're backing it and trying to figure out what the problem is. And I know several of you have already talked about this, of how did we get to where we are with the mental health crisis for kids? And it's not just because of the pandemic, but like you've heard everyone say, it made it worse. But as far back as 2016, the American Psychiatric Association issued a statement describing that we were not having enough inpatient care for youth when it came to psychiatric inpatient care. 50% of the kids, I think you did just hear this one with Ross's presentation, more than 50% of the kids with an identified behavioral health condition are not getting care. They're just simply not getting the services they need. So when they get to us, when they get to all of you, they're more acute and they're gonna cost a whole lot more. And I know you did just see the suicide rate. And like I said, I think the fact that you're seeing duplicates on some of these facts is because this is what is the most important. This is the heart of it right here, is we have to stop the suicide. It's increased 56% in the last 10 years, second most common cause of death for 10 to 14-year-olds. Black youths under 13 are 2 times more likely to die by suicide than the white counterparts. The demand for our inpatient beds has increased, but especially during the pandemic, a lot of places closed. So the beds decreased. And what we're seeing is the ED visits, the psychiatric ED visits have increased. On the heels of the pandemic, or I guess this is kind of during the pandemic, a combination of the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association issued a joint declaration. Our psychiatrists call it the sound the alarm. This is a joint statement, and I know there's a lot of words there, but really this is what is guiding what we need to do. That we need to increase federal funding for infancy through adolescence for mental health care. We need to remove problems with access. We need to increase things like telemedicine, which we've also heard a lot about. Telemedicine is such an interesting thing. Pre-pandemic, I saw those things, those mental health. I would never do that. Who would do that? That's kind of weird. I have to say that's the best thing that came out of the pandemic. Was telemedicine access to our patients, because we can reach some of the kids in the remote areas. Increasing the evidence-based practice within the schools, within the primary care settings, getting into more prevention programs, and really just sort of the getting upstream of the mental health problem. And this is really what's guiding us. The thing that our Quadrad, our ACOS group has really been working on is we're setting our 1 and 5 year goals for the hospital. We have no idea what those are going to be yet because we haven't really gotten a good handle on what the problem is. And we're new. We're really new at this whole thing. Just a little bit to show you, the mental health crisis has not escaped Cincinnati Children's Hospital. This is probably not an exact statistics. This was something I pulled out of Slicer Dicer and Epic, but just outpatient referrals to psychiatry or psychology by fiscal year. The prorated rate for 2023, which I did not have the final one at the time, was over 37,000 referrals to those two. This is some sad data, but important data to look at. These are the number of mental health outpatient visits. This is both psychology and psychiatry. That for fiscal year 2023, we had over 200,000 visits. This shows you what the demand is out there. We would have people say that based on this, then probably you should just hire some more psychologists. Well, there are areas that we definitely need help. But I guarantee you could probably hire 50 more if you could find them. And I give you 6 months. If we don't change the way we're doing business, we're going to be right back to here with a wait list and no one being able to get in. And this is a little bit of a, I think I mentioned it maybe in one of the slides in a minute, but I think one of the last slides you just all talked about workforce issues. If any of your kids are heading off to college and they want to go into mental health, it used to be when I started, and I was a psychology major, how many people told me, you can't do anything with a bachelor's in psychology? Are you crazy? You'll never make any money in the system. It's changed. I just heard a study that just came out about the top majors to be in college. Number one is still business. But when they talked about access to jobs and income, psychology majors have moved to number 2. That with a bachelor's, with a master's, with your doctorate, there are tons of jobs. The people, because of the crisis, more and more people, probably all of your agencies, are hiring more and more behavioral health techs, master's level counselors and social workers, psychologists, psychiatrists. We're all competing for the same people in the workforce, so we're running out of people in the workforce. And graduate schools aren't going to increase the number they're admitting that quickly. So I bet you, my prediction is over the next 10 years, the salaries are going up and the workforce pool are going down. So it's a really good job to go into. So encourage your kids to be a psychology major. Sorry, that's my own little, I got some little soapboxes up here. Psychiatry inpatient bed days. We have the most psychiatry inpatient beds in the country. They're full all the time. The reason this plateaus a little bit, point over here for you guys too, is because we only have so many beds. So our days are gonna plateau because there's only so many beds, but you can see in fiscal year 23, we are even maxing out the number of beds we had. We are getting ready to open a new building, 20 some days. It's going to completely change inpatient care. It's going to increase the number of beds. It's going to decrease the wait. It's going to have a big impact on this, but it's not going to make this go up a whole lot because we're not adding a whole lot of beds. So someone might also argue, well, then build more beds. Same problem. If we don't change the way we're doing business, if we're not catching these kids upstream sooner and keeping them from showing up in the ED, we're going to be filled up again. Give it a few weeks. It might slack off a little bit in the summertime, although this summer didn't really slack off a whole lot, but it will be right back up there again. This is a happy slide, believe it or not. This is one that we're actually kind of hanging our hat on, or at least one project I'm getting ready to start, is these are the emergency department psychiatric evaluations being done. We saw a huge climb, and we saw this nationally too, of all the way up around 2016, it was over 8,000 a year. That's psychiatric evaluations in the emergency room. It slacked off a little bit pre-pandemic for a couple reasons, we think. And then in the pandemic, nobody was going to the emergency room. You didn't want to go anywhere near the emergency room. But what's happening in again is it's starting to climb up, and all predictions should have had fiscal year 2023 up over 8,000 again, but it didn't. Instead, it dropped. We had 500 fewer emergency psychiatric evaluations in the emergency department in fiscal year 23 than we did the year before. That's fantastic, but I think all of you would agree that 7,000 psychiatric evaluations is probably still way too many. So in one of the pieces of my current job that I am doing a lot of is talking to a lot of different people. And I have found at least 4 different teams all working on this problem. Not talking to each other, not sharing resources, not talking to the emergency department about what we're doing to try to save their sanity. So it took us until I think the first week of November to kick off. We're pulling all those teams together, and we've got support from the hospital to do a large-scale QI project to keep the kids out of the ED, especially the ones we know about. So psychology patients seeing a psychologist, don't go to the emergency room. Let's have a plan if they're getting critical. If it's the psychiatry patients showing up, they were working on a plan, but they weren't talking to the other folks. Our Zero Suicide team will also be part of this, as well as we're working with a 4th group on fast tracking emergency situations to be direct admitted and not go to the emergency department. So my hope is if I see you again in a year from now, we're gonna bring this back. This is our starting data for this big project, and I'm hoping it just keeps going down. So that's our little bit of a positive slide. This is a mental health care continuum that we've been using to frame the mental health, all the different things that we have available in the psychiatry, psychology, DBP, all across Children's Hospital. Rather than just focusing on, up here at the top is, in case you can't read it back there, it's level 1 is home-based care, taking care to the kids where they need it. Level 2 is in the community, primary care offices, school-based services. Level 3 are what you think of as outpatient psychologist, what I do for a living, outpatient psychiatrist. Then we get into crisis care, the intensive outpatient, like we have an intensive outpatient program, we have a partial hospitalization program, and then inpatient. We tend to focus up at the top. And this is what the hospital is focused on. I think this is what you hear about in the news is the crisis, and it is important, and it's gonna continue to be important, and it's going to change, but we want to shift our focus. And I think what I had mentioned, like about the burning part, the inpatient does take all the oxygen out of the room. That's where we have to throw all of our efforts. Where we want to shift the focus is more upstream, and I think that's really the focus of what you all are doing today, and I think that is so important, is to get the kids sooner, get them younger. I think you said earlier, get them in 1st grade, 4th grade, get them sooner so that we don't have to see them in the emergency department. With our new building that we're getting ready to open up, one of the folks said, I would love that in 10 years, we have to find some other use for all those pretty new spaces, that we just don't need the beds. That would be great. The other thing that's different on this continuum that we want to move in there is, oops, wrong button. This line on the side, the arrow, what it says is robust care and case management. We don't have anybody really following these families, helping them to navigate through the community or hospital level services. So that's really where we hope to shift our focus. We do have, like I said, I don't have a ton of information around the Northern Kentucky issues, and it's really strange that we are such a big hospital right on the other side of the river. And I don't know a lot about what's going on in Kentucky. That's a problem because there's different regulations, there's different funding. We do have 2 primary care offices in Northern Kentucky that have one of our providers. This is something that we call them our integrated behavioral health care offices. I said, what if somebody at this meeting wants to put some IBH providers in their practice? And the person in charge said, just tell them to call me, we'll get somebody down there. But I spoke to 2 of them, we have 2. And I just sort of said, what are the problems that you are finding being a mental health practice in Northern Kentucky based in a pediatrician's practice? And it's exactly what you've already heard. This should not be a surprise for anyone. Lacking services, and this doesn't mean there's none, I know there are some, but not enough services, especially for under age 5. Not enough of the substance abuse services for teens. I know there are some, and they all kept saying, we know about this place and this place, but there's probably not enough. Limited access to crisis services, intensive outpatient or inpatient beds. The Kentucky Medicaid is a problem, especially around mental health. I am not allowed to see Kentucky Medicaid patients. They don't identify, they don't, see that I'm an independent provider. And so that's why, mental health for children's doesn't have a practice in Northern Kentucky, because we would be set up as private pay or private insurance only, and we would not be able to serve Medicaid patients, and we can't do that. We can't have that different level of care. Basic parent management training classes and limited psychiatry resources. So that's probably something that does not sound a surprise to any of you in here, but that's what our providers were telling us the problems. Just to give you a quick overview of what we are doing at that level 0, we do have some in-home base. Moving Beyond Depression takes services into the homes. We are partnering with MindPeace with some of the school-based mental health services. We do have people in the primary care settings. The integrated behavioral health care providers, I want to say we have 17 now, but 17 primary care practices is not a lot compared to how many there are in the area. I'm not sure if any of you have ever heard of any of our ECHO training, both for primary care practices or for mental health agencies, but that's going out and actually training other providers to do some of these services themselves. High level of training for the pediatricians to screen for the depression, to do some basic interventions for anxiety or OCD, training at a higher level, other agencies to do OCD training or anxiety training. The level 2, we have psychologists, psychiatrists, APR eds, social workers, counselors. We have a lot. Again, I don't think we have enough, especially in certain areas. And then level 3, our psychiatric intake response center, they do emergency department evaluations, they do crisis diversion calls, trying to keep the kids out of the ED, and bridge appointments. And a bridge appointment, if you've not heard of it, is exactly what it sounds like. Someone needs care now. They can survive in an outpatient setting, but they can't get in to see somebody for 2 weeks. So it bridges that gap. It gets them in to see somebody right away before they can get into an outpatient program. We have our intensive outpatient programs, IOP. Unfortunately, we lost several of our psychologists for that, so we're trying to staff that back up to get that up to speed. And partial is actually expanding. It's going to be expanding on the east side of town soon, in the next year, and then probably beyond that. And then our inpatient and residential units. What we have started, like I mentioned, is some of these integrated projects to coordinate efforts to keep the kids out of the ED in the first place. We are expanding evidence-based treatment and outcomes-based care. The difference, some people have saying, I've had people say, well, what are outcomes-based care? That's where we're collecting outcomes, but actually using it in therapy. So, and I use it for my anxiety and my OCD kids, but we graph where they are, and the kids love it. I want to see my picture. I want to see where I am. And we use that to guide treatment. You're low enough. Look at the improvement you've made. It's time to discharge, or it's time to start spreading out or moving to maintenance. We're trying to get more of our doctors to do that because what it says is that it actually shortens the course of treatment. So if we can get kids in, get the good outcomes, and get them out, I have more openings to see more kids. So we're going to be able to get more kids in without increasing the number of providers. We're also increasing access at all levels of our services, and then cultivating relationships with all of you out there. Some of the barriers, I think you've also heard, probably even better, I think in the last 2 presentations, are those insurance restrictions, insurance limitations. Telemedicine, like I said, was the best thing that came out of the pandemic, but right now we're running into big problems. We're trying to increase some of our groups. But now insurances are saying we won't pay for groups by telemedicine. So we've increased the number of groups, we can't fill them. We've had to go back to having them only in person, still can't fill them. Insurance companies sometimes stump me. Why wouldn't you want to pay for a cheaper service to get kids in faster that have good outcomes? But that's just me. And I mentioned the workforce limitations. We cannot hire psychiatrists to save our life because there's just not enough of them. There are not enough psychiatrists. There are not enough psychologists for the first time. We've got lots of ads out there and everybody's competing for the same psychologists. But even at the master's level, the APRN levels, the behavioral health specialists, we can't hire them fast enough, and we have lots of open positions out there. I think when I first did the draft of this slide, I think I had said something like, we can do a lot, but we can't do it all. And I sort of went back and said, well, I don't know if we even want to do it all. What we need to do is more, but we also need partnerships with others. We need partnerships with you to be able to get upstream, to be able to see those kids where they are. And so where we need help is partnership with the community agencies. We need more providers in schools. We need more providers in primary settings. We need to advocate. I'm glad to see a couple of our advocates are actually here from Children's Hospital today, so I'm glad they're here with us. Advocating for mental health at the city, state, and federal level. More outreach, more communication, and connections with parents, schools, churches, wherever the families are. But my question is, how do we do this? Who's responsible? How do we keep this momentum? And I think that's what is being addressed this afternoon. I think that was my last, I had questions, but I'm not gonna. All right, well, thank you very much.
Thank you, Bev. That was great. And I'm happy to report that of my 3 children, 2 of them are psychology majors, so. And one's a business major. But it's wonderful that we have Cincinnati Children's here in our community. As most of you know, they are the #1 children's hospital in the country, which is amazing for our community. So thank you for that. We're going to shift gears a little bit and move into the area of adult chronic mental illness. We've talked a lot about children so far, but we're going to talk a little bit about what we're doing for other types of patients who need our help. So I'd like to invite up Christy McGovern. She's our next speaker. She's the lead manager of performance monitoring at North Key Community Care. North Key is one of our wonderful mental health providers here in Northern Kentucky. She has a master's in clinical mental health counseling from NKU, and her professional accomplishments include leading the implementation of North Key's Certified Community Behavioral Health Clinic expansion grant and participation in the CCBHC demonstration. So she's going to start us off here. Welcome.
Good morning. Good morning. All right, well, first I'd like to thank St. Elizabeth Leadership for inviting me here to represent North Key and share what we're doing for adults with chronic mental illness in Northern Kentucky, and also where we see opportunities for growth. I hope that this information lends towards this afternoon's activities and conversations. I will be moving very quickly through the information. There's a lot to share, so feel free to grab me or anyone else from North Key at table 11 if you have any questions later or would like to talk. For those who may not be familiar with North Key or could use a refresher, our doors have been open since 1966 as a community mental health center, providing mental health, substance use, and intellectual and developmental disability services across 8 counties. Every year, we serve approximately 17,000 individuals. I didn't want to assume that everyone was familiar with serious mental illness and the criteria for that. So what you see on this slide are the criteria that one must meet to be qualified as having a chronic or serious mental illness. Moving forward, I'll just say SMI just to kind of keep it brief. But that stands for serious mental illness. This includes having a mental health diagnosis that falls into one of 4 categories and experiencing functional impairment in 1 or more life areas such as maintaining employment, taking care of one's basic needs, sustaining positive relationships. Additionally, the mental illness is persistent, or it's expected to persist approximately or more than 2 years, or may have resulted in repeated hospitalizations in a 2-year period. So I shared we serve about 17,000 clients per year. At any given time, we have about 7,000 in our system who are active, and right now we have about 5,000 adult clients at this time. And of these, approximately 70% meet criteria for serious mental illness. More than half these clients are female, which falls in line with research that shows that women are more likely to be diagnosed with depression and post-traumatic stress disorder, which are 2 of the most common diagnoses for our clients with SMI at North Key. Let me go back one. All right, almost half of North Key's clients diagnosed with SMI reside in Kenton County, followed by 19% in Boone County, with Campbell County close behind at 18%. The other 19% reside in our outlying counties, with several coming from Ohio. Now, this chart here is showing how our clients with SMI are diagnosed. Now, it's intentionally broad. Please keep in mind there's a lot of variation within the 4 diagnostic categories for SMI, but when we take a look at the diagnoses of our current clients who meet that criteria, 44% are diagnosed with depressive disorder, followed by 26% with trauma and stress-related disorder, and we're seeing about an even number of clients diagnosed with schizophrenia, bipolar disorder, or a related disorder. Many of these individuals have co-occurring issues, including substance use. Some have an intellectual or developmental disability disorder as well. Now that we know a little bit more about our clients with SMI, I'd like to share about our status as a Certified Community Behavioral Health Clinic, or CCBHC. A CCBHC is a new form of provider within the Medicaid program. It's designed to increase access to care and treat the whole person by integrating physical and behavioral health. This model uses care coordination to share information and organize care activities to improve treatment for the individual, which is especially important for those with SMI who are among our most vulnerable clients. As a CCBHC, we have to meet rigorous standards, which have helped us address some of the challenges I'll be sharing in the coming slides. The CCBHC acronym might sound new to you, but this healthcare model has actually been in the works for almost a decade. It's expanding pretty quickly across the country. We had an expansion grant that started in May of 2020 that really got the ball rolling for us. But since January 1 of 2022, Northkey has been participating in what's called a state demonstration of the CCBHC model, along with 3 other community mental health centers selected by the state of Kentucky, which you'll see there on the map. It's expected that in the coming years, more centers in Kentucky will join this demonstration. Let's get this. There we go. As a CCBHC, Northkey provides an array of services beyond individual, family, and group therapy. This includes crisis services, veteran services, and suicide prevention, psychiatric medication management, primary care, and psychiatric rehabilitation. We've increased outreach and coordination with area partners since becoming a CCBHC. We've hired teams of care coordinators, and we've expanded training for staff. We've grown our team of certified peer support specialists and started a client advisory board. So there's been lots of changes, lots of growth over the past few years to increase access to care and improve quality of treatment. Implementing the CCBHC model has strengthened our programs for chronically mentally ill adults. This list shows those programs that are designed specifically for them, or that they're oftentimes referred to. And I'll be sharing just a snippet about each of these on the following slides to shed light on what's available to these individuals at this time. Our Assertive Community Treatment Program, called ACT, serves clients with SMI whose needs surpass what traditional outpatient mental health care can address. These clients may frequently be hospitalized for mental illness and have coexisting problems such as homelessness, substance use, or being involved in the justice system. The multidisciplinary ACT team meets the clients in their home, in the community, to assist them in addressing their basic needs and also their healthcare needs. Our therapeutic rehabilitation program that we call TR offers clients with SMI daily groups that are led by a therapist and a peer support specialist. These groups use an evidence-based illness management recovery curriculum through SAMHSA to teach, model, and support clients in practicing personal, social, and daily living skill building. The Supported Employment Program views employment as essential to recovery for individuals with SMI, and our specialists partner with our clients in the Office of Vocational Rehab to thoroughly evaluate the client's employment interests, their skills, their needs, and then clients receive help building a resume, practicing for interviews, removing barriers to finding and maintaining employment that really fits what they're looking for. The Office of Vocational Rehab also provides funds for interview clothes and bus passes until that client builds up the income. Our supported housing program assists clients with SMI in applying for, securing, and maintaining safe and affordable housing. Specialists teach clients housing-related skills such as complying with safety and health codes. Case managers help clients connect with resources for rental assistance and help with utilities, as well as referring to legal aid and fair housing as appropriate. The Homeless Services Program provides outreach to meet individuals who are homeless where they're at so that we can connect them to Kentucky's coordinated entry system. This system prioritizes helping those individuals who have the highest needs and who've spent the longest time in homelessness. We also collect clients to local shower and laundry programs and other needs that they have. Our certified peer support specialists use their lived experience in recovery from mental illness and substance use to help clients to stay engaged in their own recovery process and reduce the likelihood of relapse. Peer support specialists use therapeutic individual and group activities to mentor and help clients build those skills, set goals, and share resources. They offer weekly groups at North Key on anxiety, coping skills, depression, and domestic violence at this time. Our targeted case management program evaluates the client's needs for services and supports and partners with them to develop an individualized care plan. Clients are connected to various resources in the area, including for medical, social, educational, and vocational needs. And lastly here, North Key provides support and services for participants of mental health, veterans, treatment, and drug courts. We have care coordinators in these courts to represent North Key and to assist and organize treatment for the person so that they can be successful in their program. So talking about gaps and opportunities for growth, through working closely with clients, we see the challenges that they face, and we seek to identify how we can help address those or link them to resources that can support their recovery. As we go through this list, I'll be sharing how North Key has grown over the past few years as a CCBHC to offer more in these areas, and my hope is that later this afternoon we can identify ways to partner better to bridge those gaps that do exist. There we go. I'm happy to report, especially after some of the grim things that we've heard today, that this year, Mental Health America has ranked Kentucky #1 in the nation for higher rates of access to mental health care for adults. So that's a really big win. As a CCBHC, we are held to high standards in terms of scheduling clients within certain timeframes. Looking at this graph, you'll see orange bars. Those represent the number of behavioral health evaluations that we completed in the 1.5 year period prior to becoming a CCBHC. And then the yellow bars represent the number of evaluations completed in the 1.5 year period since participating in the statewide CCBHC demonstration. And as you can see, there's actually been a 148% jump in those evaluations. And this has not been without its challenges. We've had to be flexible and pivot at times to meet the increased demand during and following the pandemic. Also, when we're talking about access to care, it means considering those whose primary language is not English. So we've redesigned our website to offer all information in 10 different languages. We've also included the international deafness symbol that will link people who are deaf to a page that goes over how to connect with North Key. We've also made care more convenient through offering telehealth visits, providing electronic tablets to clients who need one to connect to services. I know we've distributed hundreds of those. And also we have mobile care units now to take on-site to shelters and other places in the community. So we're always kind of looking for other places where we can bring those mobile care units to serve clients. A big challenge for clients with serious mental illness can be navigating the healthcare system. Knowing who to go to for help and how to access that can be very daunting, very confusing, let alone when you're trying to pull yourself up from the depths of depression or find stillness in a manic episode to make those phone calls. The lack of direction and hitting dead ends and that search for help can exacerbate mental health symptoms and lead to increased feelings of hopelessness and disempowerment. To help towards this, North Key's Health Literacy Committee, formed through the CCBHC model, has revamped our website and a number of client-facing documents using online health literacy calculators so that we're using plain language that's at or close to a 5th grade reading level. The goal is to make this easier, to know what kind of help is available, how to connect with us to get started, and also what all those pesky forms we have clients sign really mean and what they're actually saying. The financial aspect of treatment can also be very confusing. North Key has staff who we call connectors, who assist clients with insurance questions and help them as needed with completing the Kentucky Medicaid application process. Again, just trying to remove some other barriers for them and just knowing what they need to get the help that they need. A key way to help clients navigate the healthcare system is looking for opportunities for empowerment and self-advocacy. One step we've taken towards that is asking every adult client if they have a psychiatric advance directive and offering to help them create one and even having it notarized on site. This legal document serves to communicate their preferences for treatment should they encounter a mental health crisis down the road in which they're not able to effectively communicate that. Another step we've taken as a CCBHC is becoming a participant in the Kentucky Health Information Exchange, known as KHI. By accessing real-time client health information at the point of care and sharing from our own electronic health record, we're able to improve quality, safety, and efficiency of care for our clients. This also helps to remove some of the burden from them to remember and share information with us from visit to visit or from one provider to the next. One thing to note, not every provider in Kentucky is part of KHI, so that's, if we grew that number of participants, I think that would make our ability to coordinate care even stronger. Over the past few years, we've been working on increasing the number of care coordination agreements we've had with community partners. These agreements give structure to these relationships. They ease client transitions of care from one provider to the other, from one level of care to the other. For example, when a client's discharging from inpatient and going to the outpatient level of care. This is an area where we see room for continued growth, just partnering more consistently and efficiently to share information and leverage these relationships in a way that's valuable for the client and reduces gaps in those care transitions. I'd also like to mention a specific resource, findhelpnowky.org. This site was created by the Kentucky Department of Public Health. It was developed to help people find substance use treatment throughout the state. Because providers who participate in this site regularly update their profile, it offers current information on who's accepting new clients, who's offering telehealth, et cetera. This takes a lot of the legwork out of navigating the system. And I think this tool could be incredibly useful if applied to mental health treatment, and I've heard on good authority that plans are underway for a similar version of Find Help Now for mental health. There we go. Individuals with serious mental illness, especially those with schizophrenia and bipolar disorder, are at an increased risk of dying by suicide compared to the general population. At Northkey, we use a zero suicide framework to inform suicide care. And we screen for risk at every billable visit, referring clients to a higher level of care as needed. Our prevention team offers suicide prevention trainings in the community called Question, Persuade, Refer, QPR, and distributes tools for increasing safety. One of those being gun locks to give to people who have access to a firearm so that they can create more time and space for themselves from being able to use that during a mental health crisis. Our 24-hour crisis program has expanded over the past few years, including becoming a 988 Suicide and Crisis Lifeline Center. We also provide crisis intervention training for law enforcement to better equip officers to respond to somebody experiencing a mental health crisis in the community. We've also partnered with the VA and others in the community to form the Northern Kentucky Service Members, Veterans, and Families Suicide Prevention Coalition, and we are always looking for more people to join that coalition to do more work, strengthen numbers. The need at this time is to continue strengthening the partnerships that do exist and look for other ways that we can continue to work together towards preventing deaths by suicide and helping those experiencing a suicide crisis get what they need and restoring hope and other protective factors. Another need is to continue looking for opportunities to utilize the strengths of non-licensed staff, such as peer support specialists and other paraprofessionals, to bridge that gap that exists with a shortage of behavioral health providers in Kentucky. In terms of resources that we link clients to, besides our own crisis line and 988, we inform them of the crisis text line, the Veterans Crisis Line, the National Maternal Mental Health Hotline, and peer-run warm lines. With respect for time, I'll just say a few words on these additional challenges. For family and community support, we offer groups and hold events throughout the year to bring clients together, but we are seeing a need for persons with serious mental illness to connect more with each other in a meaningful way to build a sense of community and reduce isolation. Anecdotally, we're seeing this more in the urban counties where clients are needing to connect more. Our housing program has identified a gap in that landlords are increasingly hesitant to accept housing vouchers. We are working with area partners to educate landlords on the advantages of accepting those vouchers. Additionally, our suburban areas could benefit from having more resources for homeless individuals and families. For transportation, Northkey uses bus passes, gas cards, and Uber Health in certain situations to help clients get where they need to go. Depending on what kind of appointment that they have or who that appointment is with, we do refer clients to Federated Transportation, St. Elizabeth Case Management, and the Northern Kentucky Addiction Helpline. We do see our suburban and rural county clients struggling the most with transportation. With food security, individuals who struggle to be around groups of people due to the level of trauma and anxiety that they have are not benefiting as much from the food resources that exist. Also, homeless individuals need ready-to-eat meals that don't require refrigeration, so the resources that exist, which are great, and while well-intended, may logistically not work for them. These are just a couple things to consider when thinking about how to offer food security to all persons with SMI. Our last point on this slide is about finances and gaining self-sufficiency. In addition to providing assistance directly, we actually connect clients to community partners such as the Community Action Commission, Brighton Center, and St. Vincent de Paul for additional assistance. Anecdotally, we're seeing a pattern of young adults with SMI putting more focus on applying for disability than seeking to further their education and employment. Oftentimes, their parents or other family members are on disability. What we're gleaning from this is that there's a need for more hope for mental health recovery. We need to help these young people who are at the start of adulthood see and plan for a future in which they can support themselves and learn how this can benefit their mental health and lead to a sense of fulfillment for them. I will say, go off script a little bit just to say, as we're talking about hope, I do encourage us to be mindful as helpers to think through what gives us hope. Right? I've heard that word a number of times already this morning, the word hope. And so, to be credible sources of hope to those that we serve, I think it's important that we really look like what feeds me, what gives me hope, so that we can do more of that. And so that we can, again, help those we serve even that much more. So I have moved very quickly through a lot of information. And so again, feel free to connect with me and others at Northkey today if you have any questions or would like to talk more about what I've shared. Again, I hope this helps towards this afternoon's activities. Thank you so much.
Thank you, Christy. I really appreciate the point you made at the end about collaboration, social determinants of health, and all of the other aspects of mental health care that we can all in this room collaborate on this afternoon and figure out how to maybe bridge some of those gaps. So thank you for that. Well, of course, no St. Elizabeth sponsored presentation would be complete without St. Elizabeth physicians being represented. I'd like to invite Lisa Arrowsmith up. Lisa is one of our psychiatric nurse practitioners. She's been with us since 2004. She's worked in nursing homes, geriatric psychiatry, inpatient and outpatient behavioral health. She's done medication management, psychotherapy, and she's also one of our leaders in St. Elizabeth Physicians, clinical director of behavioral health. So I'd really like to welcome her, and she's going to talk about what our internal St. Elizabeth Physicians behavioral health team looks like and what we're doing. Thank you.
Here, I get 15 minutes to talk about 20 years of work that I've done, and I'm honored to be here today. So I started back in 2004 when there were about 6 or 7 psychiatric providers, mental health providers, behavioral health providers, whatever you want to call us, because as you all know, these terms have been interchanged throughout all of our organizations, and you've heard today. The slide even says behavioral health, but my actual certification is as an adult mental health and psychiatric nurse practitioner. My point there is how confusing that is for you all to understand all of those different words. How could our community and the patients we treat even know what that means? So going from 6 or 7 providers back in 2004. We have expanded. Yes, there is growth happening. The majority of that took place after 2016. And I do everything by the time I had my last kid. My last kid was born in 2016. So I remember quite well when I came back from maternity leave, there were all these wonderful new faces, these providers here that you see, and the different types that we've added to our outpatient team. So the psychiatrists are spread out amongst different locations, the nurse practitioners as well. I can tell you of the list of providers that you see there in the different types, the alphabet soups behind their name was too long to put on this slide, so we kind of tried to keep it simple. And there are probably not 2 of those providers that do the same thing every day. They're located in different places and they have different subspecialties. They treat different age ranges. What are the services that we do provide to our community and the people that we live and work around? We have a very traditional background with your adult therapy and testing. Heavy there with the adult therapy sessions being 40 to 60 minutes apiece. Our medication management, we're definitely bigger on the prescribing side of things from an outpatient perspective. We also do the work at Sun Behavioral, which you'll hear about next, but we're the providers taking care of the patients there. And our nursing homes. We have around 15 nursing home facilities amongst 4 providers that do medication management, treating dementia, treating mood disorder, treating adjustment disorder throughout our long-term care facilities. We're also at Thomas More University doing therapy. A lot lighter on the child teen side of things. I will tell you that it really wasn't until we started collaborating and working at Sun that our child teen department even grew. And that's only about 5 years old. Our site consultation takes place in all 4 of our hospitals with St. Elizabeth Healthcare and their ERs, so providing ER consults and inpatient rounds at the hospitals. And then our acute psych intervention clinic. This is similar to the bridge that you heard about from Children's. So we do allow some patients that don't have services in outpatient care to be seen within a week or so. Ideally, it would be 24 to 48 hours, but it's sometimes hard to make that work between our ER and our primary care offices so that patients that don't meet the level of care where they need full inpatient are able to get a touch with a person that is specialist and then be seen a little bit later than we'd like for them to come back and be seen, but at least it is something to get in front of them. We are also located, our main hub is Crestview Hills, Kentucky. We have between 20 and 30 patients there, or 20 and 30 providers there a day. And we have a few primary care offices where now behavioral health specialists are seeing patients out of them. They're too few. We're gonna spread that a little bit more. We'll tell you that we see about 200 to 250 patients a day. I don't know why Wednesday is so heavy, but that is our heaviest day of the week. Of the provider types we have, we'll do a visit type that lasts from 30, 40, or 60 minutes and seeing 10 to 15 patients a day. I know when you see that 44 providers, it might seem like, well, wow, how are you not seeing more and getting access improved? The strategy behind how we see our patients and what we've done to help improve our no-show rates are some of the reasons why our wait lists are so long. We are working towards some innovative treatments, though, that we feel like will help improve outcomes and then make more room for new patients to be seen. Some of those are transmagnetic stimulation, psychiatric pharmacogenomic testing, I said it, and esketamine. I do want to call the attention to the pharmacogenetic testing. We have also a department that has pharmacists that do pharmacogenetic testing, said it again, and that department's really growing. What they're gonna be able to do is integrate primary care with consults. Those consults will come from the genetic testing, and it will go over all of the patient's medications, specifically the psychiatric ones. But if we can help give those tools to the primary care doctors to help look at medicines that might be a better fit for their patients, at that level of care, we might help keep them well in that space before things get so bad that they need to be referred to behavioral health. So really great innovative research is being done there, and that is gonna be ongoing. That service is available now. And then esketamine, it's another treatment modality which is becoming more popular for treatment-resistant depression, and we're looking at that starting in the winter. So new growth, I've already alluded to this a little bit, but let me tell you the why there is not a lot of access to new patients. Since COVID, our patients are sicker. Our established patients are coming in and they're being seen, but they're not leaving. They're not getting as well as we'd like to see them to create that space. As I said before, we give our patients a really good quality visit, 30 to 40 minutes, most of them. Even the prescribers that do light psychotherapy, you're not getting out of there in under 30 minutes. So our patients are staying with us. They're getting those good quality visits. Our established patients, they're there. Our no-show rates are at an all-time low. The strategies we've implemented to make sure our patients are able to be seen have worked, and they're coming. So if our established patients are making it into 10 to 12 slots a day, there's less time for patients to see, or new patients to get in to be seen. And what are they coming in to be seen for? COVID really did a number on everyone. These things were there, but they are exacerbated. And now it's not just our children and our elderly, but our adult population and outpatient is really suffering too, and ongoing. So when we see these types of mood disorders, think about the level of care I'm talking about. It's outpatient. You don't see schizophrenia up here. You see things that we're doing from a therapy side of treatment and medication management side of treatment belong in this level of care. I also would like to call out that these are our people. This is me, this is you, this is your family members. These are the people we go to church with. These are the people we go to school with. These are the people we say who day with. But this is us, this is our community, and this is what our struggles are. These are the top 10. My partner, Sarah Mullins from Operations, did a great job at pooling these. This is our most recent data, and it makes sense for what we're hearing from our patients and what you're seeing in your community, whether somebody is telling you it's what's going on, it's what's happening. The slide I wanted to hide from the most is this slide. It's the ER visit slide. I know you guys have seen some of this data already from our community partners. I have to call out the red and the blue. So this is mental health disorders and this is substance use disorders. They are so close, right? My 6-year-old came home and said, Mom, Q and U, they're getting married. You can't have Q and not really have you. And she was so excited. And what happened in my mind, I went, oh, that kind of matches my slide. I'm gonna use that. Substance use disorder and mental health, they're married. How are you gonna get somebody that comes in with substance use disorder that says their mood's totally fine? They have no mental health issues whatsoever. So the analogy plays out, Annie gets credit for it, but it's what we're facing in our ERs. And the resources behind where patients need to go for this is not clear to the patients. That's why they're going to the ER. That 31 to 40-year-old range is scary. The 41 to 50-year-old range, we get it. So the numbers do make sense, but it's our job now to figure out how can we clarify in the community where to go, what number to call, whose name is going under what level of care. We've already heard these different organizations' names today. You've seen them up on the boards. You'll hear from more this afternoon. But it's our job now to work to clarify where to go, what level of care, and beat the stigma. So thank you, community partners. You are here. It is great to work with you. We do some actual patient care with you. We definitely trade patients here and there and everywhere. And we're also the patients ourselves that go to these places. Health Point, United Way, North Key, all of you guys here today, I can't say all your names and you're not all on the board. We appreciate you, we care about you. Thank you for being part of our community. If you take nothing else away from today, you all signed up somehow through an email or something. I've got your name or number somehow, so we will be chatting later. I feel like today is gonna be a really great step. Are we gonna conquer a lot of things? We're gonna get started on it, so thank you. I'm not done. Just 2 more slides, or 3. Stigma. I think if we flip the script, if we start figuring out how to get our words right, we're all using behavioral health, mental health, psychiatric health. How is anybody supposed to know what any of those mean if you're not actually in it? I'm in it myself, and I use the terms interchangeably. So I think if we can get the same terms right, and we help heal the whole family, the family trees that need that healing from all levels of care, starting at the basics with our food, with our physical health, with our school and education that could really get in there early for early intervention, all the way through our adults in the community, letting them know where to go, who to ask. It's okay to ask, just so simple. It's okay to ask for help. And letting our parents know if your kid asks for help, it's okay. It's not something to hide from. It's not something to ask. And then if we do our job together and make the algorithm for how to get that help right and clear and raise awareness to this is how you do this, don't go to the wrong place. I've got that laid out for you. And share that with our community because that's us. That's all of us right here. Understanding the appropriate level of care, and then of course those additional resources. If we don't do anything else also besides just collecting names and numbers and emails and meetings about meetings and emails and all that stuff, let's get together and figure out how our case management, our wraparound services can be intertwined in our community at the school level. I think that that would make a great deal of progress if we can talk about some of those social determinants of health all the way through. From our long-term care side, they need help too, to our adults and all the way down to the littles. I love this slide. It is not mine. The resource is there where the mentalhealthmatters.org is where we got it from. But for me, this helps think about the color-coded. So we've got our healthy, right? We're in the green. We're feeling good. We've got our yellow, a little bit of stress. Might need some outpatient help. The orange, we're definitely getting a little bit more serious, might need a higher level of care. And then the red, I will let Sun talk very soon because I'm trying to get done about that level of care. But if we can all get the terminology right, because we all slide on the spectrum, whatever adversities we face, whatever challenges come along the day, we could be in that green phase and then boom, straight to red. We might slide slowly, we might go right there. The moon might change. It was pretty this morning, but hard to see through that fog. And all of a sudden, our mental health is also mental illness. So I think this slide is a great idea to take to our breakout sessions and start thinking about, so is healthy mentally well? Is yellow mentally ill? Or is that mood disorder? Are we starting to talk about diagnosis? And then orange, now we're starting to get into the maybe intermediate phase of care, that level that if a patient or one of our friends would read that, go, oh, now I know where to go. I need that level of care. This is more serious. My functioning's impaired. And then the red is inpatient. And I think we could probably even categorize some of the symptoms that we have into these also. So this slide I really also enjoy because of that. I have to put a couple special plugs out there. My bosses, Dan Cole and Dr. Brown-Perrier and the leadership team with Jake and Dr. Murley have put this program together today and allowed me to come up and talk about all of the things that we're all experiencing, and we're gonna do it for substance abuse, and we're making leads and strides. And I saw Bonnie and Lisa Anglin out there and the team. They're doing huge things with Life Learning Center here today and substance use abuse. We're gonna keep doing that work. We're not gonna stop. We're gonna keep doing the mental health work. Today's just first steps. Remember, this is all of us. I have skin in the game. I've got 4 kids. I live in this community. I have family members that are texting me probably right now saying, what do I do about this? And I'm gonna say, I'm gonna help you. And I'm gonna help all of you today too to take the next steps so that as a community, as a group, you did sign up, you showed up. We're gonna do some great work today. So thank you. Now I'm really done.
Thank you, Lisa. And now I'd like to invite up the new CEO of Sun, which is wonderful. We're so happy to have him. I had lunch with him last week, and he is just bringing a new energy to our collaboration, which is wonderful. He's a Kentucky native. He's glad to be back in Kentucky. Jason Statz brings 17 years of leadership and behavioral health experience to his new role. And Sun, of course, is our inpatient psychiatric hospital in Erlanger. They also have some outpatient services. But I would just like to say that we're fortunate to have an inpatient psychiatric facility right here in our service area. We operate that in partnership with Sun. And it's an intensive outpatient facility in Lexington. They have an intensive outpatient facility in Lexington as well, with which we are not partnered. He emphasizes patient-centered practices when leading his teams towards strong patient outcomes and operational success. And he's going to talk about the resources they have related to our chronic mental illness. Thank you.
Thank you. It's a pleasure to be invited to speak here. It's a pleasure to be in this role. And just having recently joined Sun, when I accepted the role here, I wasn't exactly looking for a transition at the time. And in fact, it was as the pandemic was starting to stabilize, my family was starting to feel more settled in our community that we were in. And this opportunity came in front of me, and there were a couple of things that really stood directly out to me and drew me in. One was the philosophy and what Sun stands for, and what really drives its mission is solving unmet needs is the intent of the company. And so they really pride themselves on going into a community and understanding, listening, and being able to try to meet gaps. And having worked so many years in Kentucky, being a Kentucky native, I was drawn, one, to make a difference and make a difference in a community that means something personally to me. So I was very excited to come here, and then the partnership in the community is very obvious and very welcoming, and I appreciate the resources that are available in our community. And what I would like to talk about a little bit today is the services we provide, where we are currently and where we're headed. The levels of care that we provide are the higher levels of care, the acute levels, and that is acute inpatient, partial hospitalization, and intensive outpatient. What I've learned is we have not utilized these levels of care as much as we probably will see in the future, and as part of our planning going forward. Our goal is to help people be more successful in the community once they leave the hospital, and that's where you'll see us probably using these partial hospitalization and intensive outpatient more often in our discharging process. But how we break our services down is child is 5 to 12 years old. We have a unit specified for that. Adolescents, we have 2 units that are specified for adolescents, and those are 13 to 17-year-old kids. And the mental health is the focus of both of those programs. And in our adult population, which we're on the topic of adult right now, 18 plus, we have that broken into a couple of categories. One is acute, and that covers the severe mental illness or someone who's experiencing a severe exacerbation of symptoms and really in a psychotic episode or some kind of psychosis. We also have adult mood, and we have dual diagnosis, which includes detox, and we have a rehab component that I'm excited that we're able to offer, which is beyond the physical components of detox, being able to take a few days to focus on what's going on in the people, places, and things category and the next steps after leaving a hospital. So those are the inpatient levels of care, and for outpatient, we have partial hospitalization for adult and adolescent here, and intensive outpatient was first before I leave from partial. That's 20 to 30 hours of treatment in groups and in our setting per week, and they stay at home at night with that. And intensive outpatient is a step down from partial hospitalization, which is 13, or it's anywhere from 12 to 15 hours of treatment per week, and they still reside at home. So the idea is to help people transition from the hospital more successfully and stay more stable and are more prepared to go back to their provider in the community so that they're stable and able to maintain themselves a little bit more on their own and without so much oversight. Having worked with many of the hospitals here in Kentucky, I know that many of them have been around for years, 30, 40 years. I helped celebrate some of the milestones of those hospitals, having worked with them in the past. And I can see the growth challenges that they went through over the years and how critical that first few years are with developing their footing with what's needed in the community, where they fit. And when the pandemic hit the healthcare communities, it challenged the best of leadership teams. The most united and the most skilled leadership teams are very challenged in healthcare through COVID. And it's especially challenging to a new hospital. We were built in 2018, so we came in just before the pandemic. And as we're developing our footing and developing our part in the community, everyone's in a mask and doing virtual meetings and not necessarily partnering together live across the table and together. So I'm excited to enter the picture at this time to be able to step in and help maintain the ground that we've made, but also listen to what's needed in the community. And that's been one of my most valuable steps so far, is to take some time to step back, invite members of the community to sit down and talk about what are the needs, what's met, what's not met, and design the next steps for Sun from that conversation. So that's been great, and I've had a lot of good conversation and a lot of opportunity from what I've been able to hear. For the Northern Kentucky specifically, wanted to talk about the different counties that we've treated and what the population looks like as far as how many people are coming to our services from those counties. In Northern Kentucky, we've admitted over 3,500 people this calendar year from the Northern Kentucky communities. And how they break down, as you can see, that Kenton and Boone are, and Campbell are the biggest chunks. And then we have other counties represented there on a smaller scale. For us to be able to know what units and how to design our care, we wanted to see where are patients coming from, what demographic are they, and also by age. And then we do go into diagnosis, which is very similar to what Lisa just shared, the diagnosis types that we see. But as you can see, the 18 to 55-year-old population is the biggest population that we see, and so that's why you see more of our services right now are allocated to that. But as we have conversations with the school system, the DCBS community, and the professionals in those areas, we start to refine our next steps in those other categories as well. So this is a breakdown of those ages that we treat. And from that, our bed allocation is, as it is on the slide here, we have 25 beds for child, which is 5 to 12 years old. We have adolescent females at 25 beds. We have adolescent males, 25 beds. Mood disorder, which is the general admission for mood disorder, anxiety, depression, suicidal thinking, and those types of admission reasons. And dual diagnosis, detox, that I mentioned before, 50 beds. And that is a pretty active unit that we see with detox and moving into that rehab for the people that do take the next step to stay with us a few days beyond detox, much more ready for next steps to go to IOP, to enter Journey treatment program. And other community partners may be more of help to them if they're more stable after that few days after detox. And then the adult severe mental illness or psychosis, we have 25 beds now allocated to those admissions. And we have a population of integrity, which is our geriatric or aging population that comes into our system. And that is part of a unit, and the other part is to help overflow from those other populations that exist. For our initiatives right now, I'm really focused on understanding what the community needs, what we've been able to do so far, but most importantly, where are we headed? And what I tried to enforce or impose upon my team is to remember that we are part of a continuum, and we are part of a system here in this area that we are not successful alone. So we don't just focus on where we are, we focus on where everyone else is and what we can do to be a better part of that. And we like to understand who we can't treat just as much as we want to understand and work with those that we are treating. For instance, every day we have a huddle just to look at anybody that called in the day before that we weren't able to treat. What did that look like? Do we have opportunities to revisit this population in any way? So that's a very valuable exercise for us to know what's going on in the community that we are seeing, but also what's going on in the community that we aren't able to treat. And sometimes that generates a call the next day to see how things are going. Have they been able to find treatment? And thinking more strategically on, can we help them in any way? So I want to see our team growing in that part of the community working closer with their schools to understand what we can do from early interventions perspective and what we can do to be a partner earlier to help reduce the admission or readmission to the hospital. Really working closely with the St. Elizabeth ED staff and knowing what they go through with the urgency to get someone into the next level of care. Trying to improve those processes are part of our planning, and also working with the outpatient system here in the community to see if there's opportunity for us to be a better partner at a outpatient level too, or outpatient directly to the hospital. So those are a few of our initiatives, really focusing a lot on safe discharge planning that I shared earlier. Is part of that is the stepping down into the right level of care after. Some additional things that we do that not necessarily part of our programming, we have noticed social determinants of health are huge for how successful someone is. How well we understand that is important, and what we're doing about it is even more so important. So what we're seeing a lot of barriers around is homelessness, as most of you are probably not surprised by. We have addressed a few things internally, which is access to medication. So we have a Meds to Beds program where we send someone out the door with their medications. They don't have to go to the pharmacy. They don't have to have any complicated trips back and forth, that we send them home with that medication. And we've been able to connect over 500 people to Medicaid that were non-resource patients coming in, so that when they return to the healthcare setting, wherever they may go, that they walk in already having been connected with Medicaid, and to have some sort of ability to resource or to get into the care that they need. And so we think that's a big deal, and we really work closely with our connector, who is able to really take the next step after someone's admitted to us. We identify that they're a candidate and try to get them through as much of that process as possible. And I think making a very good attempt and dent into that. So other things that we're really seeing, transportation, we have tried to meet that by when someone steps out of our inpatient care and they're now having to commute back and forth to see us, we know our limitation on what we can do from a regulatory perspective, which we stick within 25 miles of our treatment center. So we're able to be able to shuttle them back and forth to treatment so that we can pick them up to come in and take them home when the day is over. And something that we are continuing to look at and see where opportunities may be is housing for these people to be able to get treatment. A lot of homeless shelters are overwhelmed, and mental health patients aren't the easiest patients to cohabitate in a setting like that, in a group setting. So I think there's probably a lot of development and opportunity there for us to understand how to address this particular barrier. All right, so for routes of admission for us, we see people coming from a lot of different ways. We see them coming as direct walk-ins. We see them calling and coming in. A large majority of our incoming admissions come from the ED. And what we do is try to be as responsive as possible to that. We have days like one day last week we had 70 or so, 74 calls that we were going through who had called the day prior, and looking at those calls on where were they coming from, how many were we able to treat versus who we weren't, and what did it look like on those that we weren't. But being sure that we start to meet some of those gaps and meet people where they are. If they need a teleassessment, they can't get to us, we try to branch out into using more of those virtual platforms to assess and try to coordinate as much as we can within our scope, but more importantly, where can we take our next step? So a lot of these first few months of me being with Sun has been listening to the community and seeing where opportunities are. So I look forward to working with everyone. I know there's been some challenges over the past few years, but I want to leave you with saying it's personal to me that the communities are healthy and mental health is at my forefront. This is the community that I live in. When Lisa said her kids are in this community, my kids are in this community. My family are part of these demographics in these areas that we're working with. And so it's personal to me that we play our role as a community partner here. And as we bring new people on our team, it really means a lot to bring other people on that it's personal to them as well. because it takes a village and it takes people who care, and you can't just pluck anyone off the street and let them be good at mental health just because they have a license. You really have to want the population you're working with. So I look forward to being part of these afternoon conversations. I look forward to being conversations after we finish up today and going forward. If you have any desire to talk more specifically about Sun and how we fit into things, feel free to catch me. I have my cards are with me, so we can connect either here or later on. Thank you very much for the opportunity to speak.
Thank you, Jason. We are just delighted to have you here in our community. So we've talked a little bit about kids, we've talked a little bit about chronically mentally ill adults. We're going to talk for a few minutes about some of the special needs of our geriatric population. So I'd like to invite Dr. Brittany Calico. She's one of our St. Elizabeth physicians. She's a board-certified geriatrician who joined us in 2018. She works in our community nursing homes to provide comprehensive care for rehab and long-term care patients. She lives in Northern Kentucky with her husband and children, another person right here, part of our community, and she enjoys some food and travel. Geriatric mental health and some of the unique challenges faced by this population will be the topic of her presentation. Thank you.
Is anyone getting excited yet? I think my heart's pitter-pattering, not just because I'm up here, but because this is just wonderful, wonderful information. I function as an attending physician, as Dr. Marley mentioned, but mental health affects all of my patients, and it's pretty obvious that this is needed. So thank you for letting me be a part of it, and thank you for being here to be a part of it yourselves. Little bit about geriatrics and what we are, because not everybody knows the realm that we fit into. We are a specialty that is dedicated to supporting the health, safety, and independence of our aging population. We have the unique goal of trying to meld the best clinical practices, evidence-based medicine, in combination with our patients' unique situations and care preferences. When somebody might need a geriatrician, a lot of times there's an arbitrary age of 65 and older, but it's really based on how the person is aging. As complications arise and medical conditions occur, they become more intense, and that's when you start stepping into the geriatric realm. There's 7,300 geriatricians nationwide. That works out to be about 1 per 10,000 people per population. The need is expected to increase to needing 30,000 by the year 2030, which is right around the corner. So mental health is going to be imperative to helping our aging population do well. We function in basically every realm of the healthcare setting except the OR. I'll stay away from that one. We function in both as a primary care physician, and in a lot of ways, in opportunities, we can be set up as a consultation specialty in order to help ease kind of the intense nature of our geriatric population with our primary care. We can be inpatient and outpatient for both of those roles. Nursing homes, we tend to be the primary attending physician. Our current group is comprised of 7 physicians and 4 nurse practitioners. We are currently in 9 nursing home and rehab facilities, servicing 520 patients with plans to grow, and I'm very excited about this. Little personal plug here for Saini and myself is we're going to be opening up a PACE program, and that's going to be geared towards keeping individuals who might be of a nursing home level ability, but keeping them aging in their homes. So there's going to be a lot of unique resources that are going to come from that adventure, as well as opening up hopefully a geriatric clinic in the near future. I'm going to start by talking just a little bit about trauma. That's already been plugged in very early by Robin Burrow and mentioning ACE events, and our elderly are affected by these as well. So trauma is defined as a deeply distressing or disturbing experience. It drives pain, anxiety, depression, and it sets the undertone for all of our patients who experience dementia. Those ACEs are actually an indicator and contribute to the development of dementia. So what you're doing here today and targeting the young population as well, and then treating the elderly is hugely important. 70 to 90% of the elderly have had an experience with a trauma, and 20 to 40% of those go on to develop post-traumatic stress disorder. This means that they are 3 times more likely to have difficulty with self-care, mobility, cognition, and social development. That makes them twice as more likely to develop the dementia and 12 times more likely to attempt suicide. Suicide is disproportionately contributed to by our elderly population. So while 12% of the 12% of the population attempts suicide, elder adults make up approximately 18% of that. In 2020, out of the 46,000 suicides that occurred, over 9,100 were attributed to those 65 and older. Of those attempts, 1 in 4 of the seniors will succeed, and this is in a stark contrast to 1 in 200 for the youth. Even when they fail to succeed, they are more likely to experience permanent effects of their attempt. The group that is at the greatest risk for this is men 65 and older. Why is this happening? Loneliness, such a simple term with a complex origin. As we age, as part of it, we lose our loved ones, spouses, children maybe, relatives. They lose their ability to remain independent and self-sufficient. They deal with chronic illness and pain from a day-to-day basis. They begin to lose the ability to care for themselves with their cognition and require help, and oftentimes are living on a fixed income or other stressors financially. This points back to Mr. Stats with Sun. 49% of our patients 55 years and older who are evaluated for mental health assessments were actually transitioned to facilities like Sun for a mental health admission requiring those intense inpatient care. What that means is the folks who presented for things like altered mental status, not acting like themselves, they have been ruled out from organic causes like diseases and illnesses, infections, strokes, etc., and deemed that they have been in enough of a mental crisis that they require an inpatient treatment. How do we treat this? Prescriptions, that's kind of the gimme, but it is very, very important, and it does affect the aging population differently. As we age, our bodies metabolize and things change. It gets put in different places, and there's nuances to the medications and how they work that differ based on age. So utilizing Lisa Arrowsmith and the psychiatric department who are used to the elder population becomes key. But there's a lot of things that we can do as community, as friends, as family to encourage improved mental health. These are the things that sound so simple: eat right, sleep, exercise. Very basic things, especially we as Americans, we struggle to do. I know that I do too, if we're being honest here. A big thing that hopefully it's wonderful to hear these resources pulled together is through counseling, cognitive behavioral therapy, meditation, trauma. The biggest barrier to that in our geriatric population, you're talking about the greatest generation, the silent generation, starting to get into the boomers. There is, they went through a lot, you know? They went through Great Depression, they went through World War II. Yes, I still have some veterans. Vietnam and so on, and it was very much a bucket up, trudge on, make it through, and they developed a lot of strength through that, but mental health was not a known area to focus on back then. So coping mechanisms were developed out of necessity and not necessarily the most healthy ones, and that contributes to it too. So it's important as anybody who's around these older individuals to acknowledge the hardships that either they are currently going through or have gone through and normalize getting help. Where do we get help? You will hear from Patty on the Alzheimer's Association. They deal with Alzheimer's dementia, but I'll tell you there's a lot of overlap in the different types of dementia that are out there, and they are a fantastic, fantastic resource for helping friends, family, and patients cope with the disease. In terms of chronic pain, anxiety, depression, any of those other mental health disorders, the counseling is huge. It is available in nursing homes. That's not always known. It's not very well advertised. I work in them. I don't know that our patients are being told this regularly, but there is counseling that is available. It's often more for the long-term care patients. There are outpatient services, which has been touched on so far, as well as online tablet or electronic resources that have been mentioned as well. Other points of stress that contribute to our mental health state in our geriatrics is transitions of care. So this is, forgive me if I don't mean to talk down, but I like to make sure we're all in the same playing field here. Changing from home to the hospital to other healthcare settings, whether it's a nursing home, a rehab facility, assisted living, personal care, memory care. These are all different levels of care that the healthcare system is able to provide. It is based on the patient's functionality, what they're able to do for themselves safely as determined by a physician, therapist, and team of nurses. At each point of these transitions of care, these are some important topics that, if brought up early, will make a huge impact. When we are going through a mental health crisis that's triggered by a physical one or strictly mental, it's important to have had these conversations already. You don't want to be making these decisions when you are already stressed. So these come to things like advanced care directives. Power of attorney is somebody who will speak for you if you cannot speak for yourself, and putting that person into writing is a huge benefit. Determinations as to what kind of care you want, whether or not you want the initiation of CPR. It can go further in terms of what kind of care you want in the hospital. Do you want IV fluids or medications? Do you want a feeding tube? Do you want a breathing tube or a breathing mask to push air into you? Do you even want to go to the hospital? This comes up a lot, and every patient has the right to determine this for themselves. And I think it's our job to support them and help them understand what we have available, what we can do for them, and meld that with what they want done. Some of the challenges to these transitions of care, this has been talked about ample times today, but suboptimal staffing, particularly hit by the pandemic. Not just having the right people in the right places or the right numbers, but the combination of the two. A familiarity with our patients can go a long way. When patients are in a mental health crisis, they often require more direct one-on-one care, and this puts a large strain on some of those facilities and places who would otherwise be able to accept. There are resources that are available both in the hospital and in the nursing home, such as social workers. I don't think there's enough social workers out there. They're wonderful, wonderful people and do a lot of really hard work. There's also the Medicare Star Rating for the nursing home guide is available online, and that's available to everyone. But there's no substitution for your own eyes and touring. Even as I'm sure you guys have figured out, organizations have different feels, different environments and climates, and it's the same with the facilities that our loved ones choose to live in. And so touring can make a big impact. This is highlighting some of that information in terms of the employment changes that we have experienced. You can see to the left, the 3 bars are basically outpatient settings, and they've somewhat gained some employment, anywhere from 3 to 6%, while hospitals and assisted living, those 2 smaller bars, managed to remain relatively within 1%, and then nursing homes took a big hit, losing 13.5% of their workforce. This is not expected to recover until July of 2027. So anything we can do to stabilize mental health, to get patients moved into the facilities, to help them prevent from having to send back to the emergency room for mental health evaluations, all of these things come together and are a huge, huge help. So what's the big picture? Mental health is a driver for disease processes. It leads to increased cost of care, length of stays. problematic for placement and helping to take care of our older individuals. Our elderly population is disproportionately affected by mental health, but everyone has the ability to help. You don't have to be a strict clinician to do this, you just have to be a caring individual. So my hope is today that with the resources that have been provided, what you'll do this afternoon, that we'll create a more robust and caring mental health program for all of our individuals, including our elderly. So that.
Thank you, Brittany. That was great. Next, I'd like to invite up Patty Hahn. As Brittany said, the Alzheimer's Association has all sorts of resources for our older patients. Patty is the Southwest Ohio Health Systems Manager for the Alzheimer's Association. She works closely with health systems in Dayton and Central Ohio, supporting healthcare providers, discovering their needs, providing them the strategies, tools, and solutions to offer quality in the clinical setting for people living with Alzheimer's and other dementia. So she's going to focus on geriatric mental health and dementia resources. Thank you.
Thank you guys so much for having me here. I really appreciate it. A lot of what I'm going to say has probably been repeated, but I'm going to say it anyways. During the presentation, I just want to let you know, a lot of people ask what the difference between dementia and Alzheimer's is, and I just want to say I'm using the word interchangeably today. Dementia is the umbrella term. Okay, so I know we've seen a lot of data today, but I have a little bit more data for you, I promise. It's going to be quick. So this slide right here is our 2023 facts and figures. This comes out every single year, and I want to point your attention at one fact. More than 6 million Americans are currently living with the disease, and that's expected to double by 2050. This slide here has some statistics more closer to the footprint that St. Elizabeth Healthcare has. Ohio, Kentucky, and Indiana. Combined, there's more than 405,000 people age 65 and older currently living with the disease. And the metrics below are ER visits for the disease, and the data shows people are seeking help, often for behavioral symptoms they are experiencing or other comorbidities like diabetes and hypertension. From what we know, the cost associated with the disease is extremely high and is adding to the cost of both Medicare and Medicaid. So I wanted to briefly take a look at what is Alzheimer's and how it pertains to mental health. So the first thing I do have to say is Alzheimer's disease is not a mental health illness. The American Psychiatric Association describes the disease as a brain disorder compiled of a group of symptoms that lead to a decline in mental function severe enough to disrupt daily life. People diagnosed with Alzheimer's disease may display similar symptoms to those with mental illness, such as a loss of interest in hobbies, using poor judgment, and personality changes. So where do Alzheimer's and mental health meet? I know we've talked a lot about stigma, and it is so important to talk about that when it comes to Alzheimer's and dementia as well. They both have denial and stigma as two common denominators. Individuals who deny change in themselves, or family members who deny changes taking place with a loved one, they're only extending the inevitable. Stigma is the use of negative labels to identify a person with a disability or illness and is really often driven by fear. Some of the symptoms associated with dementia are similar, like I said, to those displayed with mental illness. Some signs of mental illness may be bipolar disorder, schizophrenia, or extreme anxiety. It is crucial to be diagnosed by a healthcare professional who specializes in brain disorders to go through and separate the symptoms into the correct diagnostic category. Now, historically speaking, people think of the Alzheimer's Association as a social service agency focused on supporting those at the time of diagnosis. But with our health systems initiative that we began in 2019, we are supporting health systems and clinicians on quality improvement projects that help with driving earlier detection and improved care management. I'd like to share a wonderful example with how we're doing this work right here within St. Elizabeth Healthcare. This slide right here represents the age-friendly health system and the 4Ms framework that goes along with it. There's a lot of information in each of the buckets, but I just want to go through the steps that they are taking as the project team in making this happen and becoming an age-friendly designated system. They are currently working on addressing the 4Ms model and potentially becoming a designated age-friendly hospital. The project team is currently piloting the 4Ms communication to standardize patient care in Florence at their medical surge units. The team is addressing what matters for the patients by utilizing their All About Me clings for their patients and families, and are currently working on getting the information into the Epic system so it can follow the patient across care settings from encounter to encounter, and for the patient's outcome goal to have this information in their individual care plan. During this pilot, they will also have the pharmacy team looking at what matters to the patient by looking at their medications. Certain medications, such as opioids, sedatives, sleep aids, and muscle relaxers, can really interfere with the patient's mental cognition. For the mentation component of the 4Ms, comfort kits for distraction are currently waiting on final approval for the supplies to be ordered, but these are going to be kits that can be given to patients based on what they're currently interested in, help keep their mind occupied while they may be in the emergency room. All of their steps are in place to utilize the kits, and documentation of patient preference is in the works. They have plans to have physical therapy consults for the mobility piece, as well as set the expectation that patients should be up in a chair for meals and should be ambulated during each shift. So as the association, we have a lot of opportunities to support patients, caregivers, and clinicians' patients. So not only do we have our community resources and local resources for patients and caregivers, we also have them for health systems and clinicians as well. We are most known for our 24/7 helpline, 1-800 number, and our website, alz.org. Some community resources consist of, again, that 24/7 helpline. We have our local resources. We have support programs, education programs. We have early stage social engagement programs, online tools, and safety classes as well. And these are just some of the examples of the resources that we have. I highly encourage you to visit our table out there. Kelsey and her team are out there ready to answer any of your questions in regard to our community or local resources. For local, we have the virtual and local in-person education. We have our support groups all across Greater Cincinnati, Northern Kentucky, and we have our online education and training. So what we do know, we know that we must work towards removing the stigma, just as it is with mental illness, that has plagued health issues affecting the brain, because without a proper diagnosis and treatment, dementia and mental illness are not going away on their own. That's it. Thank you.
Thank you, Patty. That was great. And she brought up a great point that we do have out in the hall all sorts of partner tables. I know I've seen a lot of you talking to those folks out there. These are community agencies that work in the mental health space, the substance use space, that help us manage some of these problems. So I'd like to thank all of our terrific speakers who helped us prepare for this event and their preparation for this and the ability to just be with them today and hear what they had to say. I saw the deck in advance, but I really enjoyed hearing all the presentations. We've heard about the current state of mental health and many of the services available in our community. This afternoon, we'll have a different opportunity to brainstorm some collaborative ways to address some of the gaps that we've identified. We're going to talk about how do we improve access, decrease stigma, crisis services, community education, some of the things that Christina showed us in the word cloud when we did our survey. What are the things that we really need? What are some ideas we can put together? And I like Lisa's idea of having easier access into the entire continuum of what all of us do together to take care of patients. So for lunch today, we are fortunate to have Center Table Catering. If you don't know about Center Table, there are some interesting things about their story. Erica Owens, I believe, was going to join us, and I'm not sure if she's made it yet. She may still be getting things prepared for us. Yeah, one of our other representatives from Brighton Center can come up. So Erica works as a food service manager at Brighton Recovery Center for Women and Center Table Catering, and Brighton Center has done a lot of wonderful work in this space. And Center Table is a way for patients who are kind of getting back on their feet to learn a trade and be able to do things from a career standpoint. So that's really great. So Melissa.
I assure you that Erica's story is going to be much more compelling than mine, but you will see her out there and she'll have a chance to share it with you. So Center Table is catering with a purpose. When we started the Brighton Recovery Center for Women as part of Recovery Kentucky, it was really important for us to think of all aspects of what women are facing in their journey. And so when looking at recovery, reemployment, skills, having an opportunity for women to share their story with each other while they're working shoulder to shoulder, gaining job skills through catering, interactions like this, having a chance to meet you all and talk with you as they're serving, and having that opportunity to really build that resume as they go back out. And beautiful Erica is right here. So thank you for that's right. Erica, I always got your back, okay? That's right. All right. Erica Owens.
Thank you for being here.
You're welcome. How are you?
Good.
Sorry, guys. We always like to come in with a bang, so a little construction on the road when we were coming. My name is Erica Owens. I'm the food service manager of the Brighton Recovery Center for Women. I also run Center Table Catering. I'm out of breath. Sorry. So I'm going to give you a little backstory about me real quick while they're setting up, and then I'll tell you about Center Table and stuff. So I was a resident of the Brighton Recovery Center in 2019. It took me 10 months to complete. 2 months later, they hired me. I've been there ever since. So I have over 4.5 years sober. I used to hate that I had to ruin my life to get where I am today, but I don't regret it anymore because that's why my life is so amazing today and that I get to help other women. So, because this was evidently what God had planned for me. So, I'm sure, Melissa, did you tell them about the Recovery Center? You did? Okay, so let me tell you about Center Table. So, we're a nonprofit catering company that's ran out of the Brighton Recovery Center. And the girls, when they get so far, can volunteer their time to be on the catering team. And when they do that, then they get job skills to go back out because about 60% of our women go back out to work into the food industry. So they can get their food service manager license while they're there, and they get the skills that they do. One of our peer mentors who works hand in hand with us when they get to the end of their process, she is now the food service manager of the jail in Carrollton. So that's the success and things that they get to do. I was a peer mentor in there also. My favorite thing about Center Table is that it shows the world the face of recovery instead of the face of addiction, because we don't look the same as we do when we're homeless. So we cater to tons of things for St. Elizabeth. They're so good to us. One of the biggest things is we love to do EVS week with them. We do Dearborn, Indiana, Fort Thomas, Edgewood, and Florence. So they keep us pretty busy, and we do Christmas with them. As far as how much St. Elizabeth means to us, they are the doctors that are in the Brighton Recovery Center, and also this morning our mental health doctor was there, Molly Lutz, and she said, when you go there, you better tell them that I'm your doctor. And I said, you got it. I'm going to tell them all. So we believe, how important mental health is. So I will brag on us a little bit really quick because this is a big to-do. So I got hired in 2020 in March, and 2 weeks later, the pandemic hit. That was exciting, right? No. So about 3 months after that, we had no invoices because we didn't have any orders. And my boss said, Erica, we're not doing so well. I said, please don't give up yet. Just give us a little bit of time. So we got creative and we did things that were COVID friendly, like box lunches, and we did cake pops and hot chocolate bombs and any creative thing that the kitchen and the girls could come up with so that we could stay afloat, and we did. We never got in the red that year. This last year has been our most successful, and my boss budgeted, I think it was $58,000, and we made over $160,000. So. All that money goes back into the recovery center to help women in their recovery process. My goal lately is I want to buy them new beds while they're in there. So that's our goal this year. They just got new floors and different things like that. They got 6 sets of washers and dryers. So, because let me tell you, 100 women in there, you need a lot of washers and dryers, A lot more than you think. So I really want to thank you all for choosing us to be here with you today. We enjoy it, and the girls, I'm pretty sure, are getting ready to walk in. I'm not really sure. They're setting up out there, and I hope you enjoyed your breakfast. I'm sorry that was my director here this morning because we had another delivery at breakfast. And then we're doing your lunch, and I hope you enjoy it, and it was so nice to meet all of you.
Erica, thank you so much. We're so excited to try your lunch today. We had a great breakfast. What a great morning. I'm so happy with all the presentations and all the discussion that I'm already hearing between all the attendees. So.